femoral component loosening. I thought we are sitting in hip or a knee.
No, that's a background.
No. His first slide, I could not read that.
What he's saying is that, it doesn't matter what webinar you have, displacement will be there.
You can't blame me. I put a message to Dr. Rashid that please don't include me if you can.
That's precisely the reason we wanted you. Because you told me, do this. So I said, no. First slide.
Monty sir,
What he's saying is that, it doesn't matter what webinar you have, displacement will be there.
sir, we are live on YouTube now.
You can't blame me. I put a message to Dr. Rashid that please don't include me if you can.
That's precisely the reason we wanted you. Because you told me, do this. So I said,
Monty sir,
Unmute. Monty, unmute.
sir, we are live on YouTube now. Sir, we are live on YouTube now.
Yeah.
Are you able to hear me?
Yeah.
Yes.
Okay, and seeing the slides also?
Yes.
Yeah. So we'll start in 2 minutes.
Karthik, કેમ છો?
All well. How are you, sir?
Yeah, fine. So today you are in the appropriate platform.
Thanks to you.
Is it not 6 yet? 1 minute.
1 minute to go.
Yeah.
Asit, will you confirm from Anil or else we'll have to go with Prof. Graichen's lecture first.
Right. Okay. Now we don't have his cell number. That's the thing. Should I drop him a mail or something? Or
Prof, you are okay with talking first if Anil is delayed?
Yeah, no problem. I'm fine with that.
Okay, that's fine. So Asit, you can do that.
Okay.
So we'll start now at 7 o'clock. Okay.
Right.
Yeah, Anil is joining.
He's coming. Yeah, he's joining.
Seven, yeah. Could you mute? Can I request all of you to mute yourselves? Good evening, dear friends. I am Subhranshu Mohanty, President of President of Indian Arthroplasty Association. I welcome you to the webinar of Indian Arthroplasty Association. This is the Silver Jubilee year. We started in 1995. And the Silver Jubilee year became the pandemic year. And you can see all our activities in our website, www.indianarthroplastyassociation.com. And if any suggestions, I welcome to write to us at indianarthroplasty@gmail.com or in my personal email ID, drssmanti@hotmail.com. Dear friends, we have created 2 WhatsApp groups for the life members of Indian Arthroplasty Association, and these are named as IAA1 and IAA2. If you are not a member of any of these 2 groups, then please send me a message in my mobile number, which is written below, so that I can put you in the group. And we send all our, postings in these WhatsApp groups and do the case discussions as well. Now today, it is the Indian Arthroplasty Association 360-degree webinar series number 11. All these virtual platform meetings were started in May after the lockdown, and we have been continuing now every monthly on the 3rd Tuesday of every month. And this is the 11th of its kind webinar. And today it's devoted to unicondylar knee replacement. And none other than the convener is Dr. Asit Shah from Technic Clinic from Mumbai. And he is going to maximize the minimum of unicondylar knee replacement along with our faculty. Now you are live on YouTube and Facebook, so you can see us on YouTube and Facebook. Post your questions on the YouTube or Facebook, then we can take your questions and discuss among the faculties. Dear friends, today I have 2 distinguished, invited faculty. First, Dr. Anil Ranawat, and probably Indian orthopedic surgeons need no introduction, for Dr. Anil Ranawat. Every year in the ROC, you see him, we discuss with him. He's a great friend of, Indian Orthopedic Association and Indian Arthroplasty Association. He's at present the Chief of Hip and Knee Division of Sports Medicine Institute at Hospital of Special Surgery in New York, USA. He's the Associate Professor of Orthopedic Surgery at Weill Cornell Medical College and Associate Attending Orthopedic Surgeon at HSS as well. At present, he is the Medical Director of Physician's Assistant Department of HSS, the largest physician assistant department in the world. The Assistant Team Physician of New York Mets, Assistant Team Orthopedist for New York Rangers as well. He specializes in biological restoration of hip and knee joint. When we all talk about chopping up of the joint, Anil always talks about preserving the joint, and that is how is Anil Ranawat. He has numerous peer-reviewed publications, chapters, and has authored 3 books to his credit. It serves on numerous orthopedic boards, including American Orthopedic Society of Sports Medicine and Eastern Orthopedic Association as well. On behalf of Indian Arthroplasty Association, I welcome Anil Ranawat today for his delivering his guest lecture.
Thank you, Dad. Oh, sorry.
Oh yeah, Anil, welcome. Nice.
Thank you. Welcome.
Thank you.
Finish your introductions.
Yeah, sure. Our next guest speaker is Professor Dr. Med Hao Grin, and he's also very well known to Indian Orthopedic Associations. At present, Professor Grin is the Medical Director of Asklepios Orthopedic Clinic at Lindenloh in Germany since 2011. He specializes in unicondylar knee, total condylar knee revisions, cartilage and arthrosis research, and 3D joint kinematics. With the membership in many medical associations like AGA, DVAC, DGOAC, etc. And regarding the journal and publications, is a member of the editorial board of Clinical Biomechanics, and approximately 350 publications, and he has got abstracts in many Congress volumes as well. We welcome Professor Grin today to this webinar. Professor Grin, thank you very much for joining today.
Thank you.
Now, in addition to our invited guest faculty, we have our own Indian faculty who are going to highlight our different aspects of a unicondylar knee. Among them, Dr. Rakesh Rajput, who is the Director and HOD of Orthopedic Surgery at CMRI Hospital, Kolkata. Dr. Karthik Shukla, Consultant Orthopedic Surgeon from Ahmedabad. Dr. Kamal, he is from Gurgaon, New Delhi. Our President-elect, Dr. Rajesh Sharma, is from New Delhi. Dr. Pradeep Bhosle, who is the Director of Joint Replacement Surgery at Nanavati Hospital, Mumbai. And Dr. Krishna Kiran, who is the Director of Orthopedics at Medicover Hospital, Hyderabad. So, dear friends, let's move ahead with the webinar. And now I hand over the proceedings to our convener, Dr. Asit Shah. Dr. Shah, please.
Good evening, friends. Good morning to Anil and good afternoon to Professor Greichen. So first of all, let me thank Dr. Mohanty and IAA for this excellent opportunity. We are discussing a newer topic in replacement surgery, and that is the unicompartmental knee replacement surgery. As we all are aware, compartmental arthritis is something very common. And we as a surgeon, we sometimes have to decide whether we can offer that patient a total knee or a UKR. Sometimes in India, even the patients tell surgeons to perform a particular well-known surgery rather than this UKR surgery. So all these questions will be answered here. The way we have constructed this webinar is first two guest speakers are basically Dr. Ranawat and Professor Greichen. They will be talking about understanding and explaining what is compartmental disease and what is the best treatment for them. Professor Greichen will speak about the results. And then we have all our other Indian faculties who will topic by topic try to cover all the aspects of UKR. So without wasting much time, can I please invite our first speaker, Dr. Anil Ranawat? Please, he's going to talk to us about why UKR, the treatment rationale for compartmental arthritis. Over to you, Anil, please.
Thank you very much. I'm going to share my screen.
Yes, we can see, we can hear you.
Okay, and let's just go to slideshow from the beginning. Okay, can you see everything?
Yes, we can. Very clear, loud and clear.
So thank you. I do have to run to theater in about a half hour, so but I am so honored to be here, and it's I was with some Indian friends and some of you this weekend on the ski meeting, and now we're here. And thank you, Dr. Mohanty and Dr. Shah, for the invitation. I do always love this because I remember 10 years ago when I first talked about robots and partial knees, I saw a lot of kind of squinty eyes in India and a lot of skepticism. Total knee was the way to go. But just as I think I slowly converted my father, we see the Indian market evolving very dramatically and fast too. So I'm going to talk about some more philosophical points and maybe get into a little bit about surgical details. These are my disclosures, not relevant really. So, obviously as a society ages, our demand for arthroplasty increases. But as we do more aggressive arthroplasty, so do revisions. I do think a total knee, if you do enough of them, can be a morbid operation. It can be a dangerous operation. With COVID, we saw we really had a lot of restrictions in the U.S. who could get a knee replacement based on age, BMI, a lot of factors. Those have been relaxed, but now they're kind of coming back again. And then the bottom line is that a total knee for a very active person isn't about 30% are not happy with a total knee. For a large deformity, Indian patient, that has a 15-degree varus knee, a total knee is the way to go. And you're going to make them very happy if you do a good job. But for, that 5 to 6 degree knee, a uni has a lot of numerous theoretical advantages. And why I still, like a uni? Well, because you retain the cruciates, you're going to have improved kinematics. You preserve the cruciates, so you'll get true rollback. It's a much quicker recovery, and you can use a lot of advanced stuff, robotics and navigation, to be really precise. And that's why I think a lot of historical unis haven't done well, because it's really hard to do it. If you keep your cruciates, it's hard to make your alignment perfect. One of the things my dad always says that no total knee will have normal kinematics if you cut the cruciates. And now we're trying to do cruciate retaining total knees, and I think that's some interesting things about the future. But then you got to talk about condylar geometry. You got to talk about alignment. There are a lot of things to do. So it's not just the panacea of just retain the cruciates with total knee. So, what do I really love? This is I consider a uni as a resurfacing operation, because not only do you preserve the cruciates, but you maintain the proprioception of the ACL. And that really is, if you think about a forgotten joint index, which is a level of you actually, when you forget when you have a replacement, clearly the forgotten joint index from a well-done total hip is much higher than the forgotten joint index from a total knee. And that being said, a uni is more on the forgotten joint index of a total hip. So, why do I use robotics? Well, it's all about durabilities. Unis had a lot of inferior durabilities. If you look at all the registry data, but I think a lot of that's based off historical data. I think you can have a lot of most common causes of malalignment, which is in the frontal and sagittal plane, which is cause of failure. There's a steep learning curve, and we've seen how effective robotics have been in heart and prostate surgery, which has really been very heavily penetrated in India already. The other reason why I like robotics, because it has 1 millimeter of accuracy, and in terms of alignment, it can eliminate alignment problems. It can eliminate early failures of edge loading, overload of the lateral compartments. It actually eliminates the steep learning curves of unis. I think a total knee to do perfectly is a hard operation. To do an average total knee is not that hard of an operation. You can really make a uni bad quickly. It's hard to make a total knee bad quickly. It's a little more forgiving because you have better exposure. But realize this, robotics navigation doesn't go against fundamental arthroplasty principles of fixation and selecting the right patient. That's still always the rules of my father, and it's not fancy robots. Navigation doesn't never replace proper surgical technique and good surgical experience. So is the robot accurate? Yes, we've shown this in multiple papers where the robot is superior than conventional techniques. We've also shown that we can get accuracy up to 1 degree of malalignment. So I'm really a fan of robotic partial knees because it really eliminated my outliers. And my outliers in partial knees failed much more dramatically than my outliers in total knees. We also can do a lot of ligament balancing to 1 or 2 or 3 millimeters, which to me is much more important when you're really trying to restore kinematics. When you have a large deformed knee, you're trying to restore kinematics within 3 to 4 millimeters. When you have a small deformed knee, you want to restore kinematics to 1 to 2 millimeters. So you really need some more fancy tools to get you that. It's also been shown that, the learning curve. The biggest problem, I think, with unis, with resurfacings, with more advanced arthroplasty, is there a steep learning curve, and you don't have as good as exposure, right? My dad always said, surgery is fun when you can see. Well, because of the cruciates, you can't really see that well. It's more keyhole surgery. It's more attuned to, I'm more of an arthroscopist, and it really eliminates the surgical learning curve. So let's just go through quickly what the robot is. When I first gave this lecture, none of you guys know. Now there's, maybe 5 or 10 robots or different robots all throughout India, maybe more. I'd be curious what the number is right now. It's really using a haptic feedback, and the haptic feedback controls the burr, and it gives you zones of penetration and of protection. Looks like that video is not working. So when do I do it? This is clearly, I'd say, probably the most important slide. You have the Dick Scott Classic 1989 indications, and you have the Oxford indications. Dick Scott's saying about 6 or 7% of total knees, and the Oxford indication is about 33%. And like everything in life, the answer is usually somewhere in the middle. Obviously, you want people who are a little bit older, but also a little bit younger. You want bone-on-bone arthritis. You want an intact ACL, but I have done it with a partially torn ACL because it is a fixed bearing component, the one I use. You want, as close to a normal lateral compartment. I'll accept a little bit of conjugal wear on MR, not on an X-ray. You ideally want correctable varus, and this is where your physical exam is very helpful. You want to have some lengthening of the MCL. Now, again, because I use a fixed bearing, as I've done more and more of these, I was taught never to do an MCL release on a uni. Now I do a pie crust technique like my dad's talked about. I've done that on a lot more varus deformities that are not fully correctable. So don't be so worried about that. I plicate that, I lice the POL. I also don't want a huge flexion contracture, but if I have a small one, I can deal with it again with a pie crust technique. One of the things I think is very important in the Asian population is bone quality and bone stock. You don't want to have a lot of cysts. You don't want to have a lot of osteomalacia. So it is a problem on my Asian, I operate in a lot of Indian, and Indians that grew up in India where you have vitamin D issues or fluoride issues. So I am a little bit more cautious with them, but you really want to make sure their bone is scleroticized or has some whitening of the bone so it can take an implant, because you have a lot of pressure going through a small implant, and that's why your cement mantle matters. Where I don't care as much, I don't care as much about the patellofemoral joint, chondrocalcinosis, their age, their activity level, and obesity to a certain extent. Obviously, morbid obesity is a problem, and I don't do unis on those patients. So let's just do a quick case study, and then this is a 58-year-old. So one of the things Dick Scott used to tell me when I trained with him, my dad's good friend from Boston, he's like, your partial knee should be either your first or your last replacement. So, I'm a little bit on the younger side or a little bit on the older side. Used to be very, very active, has 2 years of knee pain, now has limitation on walking, forget about sports, and he's done everything. He's done every injection, and he can't really do that. And you can see here, you have isolated medial compartment, right? Patellofemoral joint on the sagittal looks good, and the lateral compartment is good. I don't do stress x-rays. I know how to examine a knee. I can examine a knee A to P for ACL, and I can examine a knee coronally for MCL laxity. I think stress x-rays are a bygone product of early Oxford stuff. I do think a lot of these patients do come in here with an MRI and will say, oh, I wanted my knee scoped. And you can also look at the lateral compartment on that. But I think stress x-rays doesn't have a role because my fundamental goal of a uni is, let's say, a 6 degree, 7 degree uni is to undercorrect to 3 degrees, right? I want to restore constitutional varus and constitutional alignment. I'm not trying to get a full 0 degree mechanical axis alignment correction. A critical point that was never proven in the literature, say 7, 8 years ago when I first started talking about it. And now in the uni literature from mostly Joel Argenson, he's shown it in multiple papers that undercorrection is the way to go for unis. So here's a long leg cassette. I love to do long leg cassettes because I want to marry my alignment deformity pre-op to post-op, and I want to get about a 3 to 4 degree correction. That's what I'm always thinking about for a uni is I can correct with the robot or with the uni 3 to 4 degrees, not much more, not much less. I'll quickly go into technique. This is how we do it with the robot. You prep and drape. I use a single shot spinal and a saphenous nerve block. You register the bone. You do your valgus correction before the cuts. And then you register the robot. Then you do your burring. And then you do your trialing and kinematic analysis. And then, to me, the most important part of the operation is exquisite cement technique because I have a small surface area of the bone. Again, it's CT based. To get the right components, you need to get a preoperative CT scan. We could talk about the cost with that. That is an issue. And then, as I talked about, the anesthesia setup, spinal, but I do use a saphenous now, no femoral nerve block. And this is how you do limb registration. You have to have some space for the robot in the room. And then you do your exposure. Some of my unis have bigger exposures to my total knee because I do not evert the patella. I just sublux the patella. And then that's how you register the robot, the femur based off your CAT scan. And then this to me is what I like the most because I look at the preoperative coronal deformity, so say 7 degrees, and then I understand how much MCL play is based off my physical exam. Then I do a valgus correction, and I want to get that 7 degrees to about 3 degrees. That's where I usually live. I can play 1 or 2 degrees by increasing my poly. If I increase my poly, though, then I'm going to have to do more of an MCL lysis because I want to get this flexion extension gap balancing to about 1 to 2 millimeters loose and from 0 to 90 degrees flexion angle. And that's really the key to the technique. And then last, you register the robot and then you burr. And usually at this point with the burring, I'm not even doing it. It's the resident and the fellow can do the burring. It's really not that difficult. And then it's the tibia. And then you can do various different options. You can do all poly. I do all onlay, but I used to do all poly when I first started. And then I do some trials. And then, as I said, cementing. So in terms of post-operatively, half my unis go home the same day. We do the ROC cocktail. I always put them on aspirin. I used to use a drain. I don't use a drain anymore. But I'd say the other 50% of my unis go home the next day. And they don't ever go to rehab. And they start physical therapy immediately. And then usually by 2 to 3 weeks, they're about 70% back. In about 6 weeks, they're about 80 or 90% back. That's kind of my standard protocol. And this is an example of both fixed bearing, one all poly tibia, one metal backed. We have a non-cemented option, but it's still not available. So, I do think, unis are an amazing operation. The forgotten joint index is a great thing. They're technically more difficult, so using more advanced tools. I love osteotomies. I still do a lot of osteotomies. Osteotomies are for a disease when you have a joint space and you're a little bit more younger, a little more technically demanding. When you don't have a joint space on a weight-bearing x-ray, a uni is the way to go. So, when I started giving this talk, the robot in America had a few percentages. Now it's about 15. It's actually now 20% of all unis in the robot are done. And every year or two, this data goes up, and it's going to be about 30 or 40%, they think, in the next 5 years. So I always say, if you had this hip fracture, would you not use fluoro? And I say, of course you would. You would do it robotically. But my dad still says unis are the work of the devil. But when they work great. So sometimes you may have to hug the devil. I've hugged the devil. Thank you very much.
Thank you very much, Anil. That was an excellent talk about various aspects of unicompartment knee replacement and the way you do it at HSS. I understand you have to leave for your clinical duties. So if there are any questions, can we sort them out? Are there any questions in the question box, chat box?
Can I ask one question?
Yes, please, Dr. Bhosle.
Harish, then Dr. Bhosle. Yeah, Harish.
Harish Bende first.
Hi. Yeah, can you hear me?
Yes, yes.
Hello?
Yeah. Yes, yes.
Just like 15% people in TKR are unhappy, even if it is done in the best center and with the best possible technology. What is the percentage in uni? How many of the people are unhappy? Is that number lesser, same, or more? Have you ever done a study on that? How many of them are really not so happy about it?
Harish, that's a great question. And first of all, I'm very curious what your background is. I want to go back to those mountains look beautiful. I wish I could be in India with you traveling in those mountains. But I would say the best answer to that is 100% of unis that get revised are unhappy. So if I was speaking to your father-in-law or to my dad, that's what they would say. So 100% of failures are unhappy. So that's the total knee conservative camp. But then you look at my failure rate, and Martin Roche, one of the big original Mako guys with me and a big now striker guy, just presented his 10-year data of under 1% failure. Now, take that with a grain of salt because it's kind of like Oxford data. It's a little bit more single surgeon, and Martin's a great surgeon. But there's so if you have your failure data under 1%, and you're saying, wow, that's really low, then I would say my unhappy unis are about 5%, because I do inject unis once in a while for contralateral disease. I do have people that have anterior knee pain after unis too, because the patellofemoral joint's still not perfect. So it's clearly better than total knees, not even close in my experience. It's about 5 to 7%. But that being said, I will, my first line, if you look at registry data, when you have 30% failure rate at 10 years versus say 5%, 100% of those people who get revised are unhappy.
Oh, that I agree. Not the failed one, the knees which are going on. Can we say that this is more forgotten joint than a hip?
Yes, I can send you the paper. That's no, not than a hip. No. I think it's than a knee, but not more than a hip. No, I still think a hip is better than even a uni, because no one loves an incision, my dad would say, in the front of their knee. No matter what operation you have, even if you have a big osteochondral allograft, or I do a lot of young people's knee, if you have a big incision in front of your knee, you can't kneel. That's going to make it not a forgotten joint. So an arthrotomy by definition makes it harder to be a non-forgotten joint. So yeah, I want to be clear. Total hip is the best, then uni, then total knee in terms of the forgotten joint index.
Okay, thanks.
Dr. Bhosle, please.
Yeah, very basic question. ACL integrity, how do you preoperatively assess whether the ACL is intact?
Good question. I mean, I'm a ligament surgeon, so I spend hours teaching my trainees how to examine an ACL. So I have no problem. You could look at the Oxford literature, right, where you get standing lateral X-rays and they look at tibial subluxation. that could be done well. But I mean, I think clinically, assessing a Lockman in 30 degrees of flexion is all you need. Don't be so intimidated by ACL signal on an MRI or ganglion cyst formation on an MRI, because a lot of ACLs with ganglion cysts that are 67 years old are still quite functional. And the other advantage of using a uni, if you do think you're worried about the ACL, I can do a slope reducing uni. I can really dampen out the slope. And I wrote a paper on that. So if I don't have an ACL at all, I will do a 0 degree tibial correction. And that gives me some A to P stability. I don't think you have to do x-rays, but one thing you want to realize, you look for anterior medial wear. When you get posterior tibial wear, you know the tibia is drifted anteriorly, and you know it's total knee land. And so you should always be able, looking at posterior tibial wear, you know that ACL is out.
Okay, great.
Anil, can I ask a question, please?
Sure.
Do you have any patient, subset where one side they had total knee and the other side they had UKR, that is partial knee? And what is their outcome 5 years, 10 years down the line? What would they like? Because that will be the really patient reported outcome.
Yeah, so I have to, my disclosure is I don't do total knees anymore. All those my brothers go. So they get a partial knee by me and a total knee by my brother. So this gets very familial contentious. And I will say, although I really want, I'm an honest person, and although my brother would say the opposite, I would really say that my unis are better. My brother does very good total knee technique. But that being said, my brother refers me all his unis. So it's really picking the right patient. It's very rare do you get a similar deformity and you try one versus the other. It's usually my knee is a post-meniscectomized knee, intact knee. His knee was a multiply operated on knee that has a 10 degree deformity. So, but I can think of 2 patients where, they like their total knee more than they like my uni. And I can think of 3 or 4 where they like my uni more than their total knee. But, this is that question gets to really family issues.
Okay.
Do you use tourniquet?
I only use tourniquet for cementing, like my dad.
Yeah.
Right.
Okay. Can I ask a question to Dr. Anil?
Yes, go ahead. That's the last question, please.
Yeah. Dr. Anil, you mentioned that you do under-correction in case of uni by 5 degree or so. So you mean to say you are leaving, because in case of uni, there is, if we don't want to overstuff the lateral compartment, but how do you manually judge that you are leaving it under correction? Because most of the time concern is also about spin-off and other things. So like you pre-operative plan or you do per-operative this planning, how do you go about it?
So if you want to think of coronal deformity of the knee, the average male knee is in 3 degrees of varus, born. And as they get more deformed, they go, to 4, 5, 6. Once you get, if you took a weight-bearing X-ray, you go and draw your kind of axis line through your talus, and you get medial to the compartment, that's 10, 11 degrees. That's past uniland. So if you want to say Oxford land is anywhere from, say, 4 to 9 degrees of varus, which, I could do it based off my preoperative template. I could do it based off my bone resection. And I know on my average, my unis are 3 or 4 degrees of correction. So if I know preoperatively what I have, I know. Because I can template how much bone I'm removing and I can measure that. Now, that's the old way of doing it. I have a robot, so I know exactly what my coronal alignment is. And so when I don't undercorrect to 5 degrees, I say I want to get to 3 degrees. So I want to get my weight-bearing axis to the medial spine, not to 5 degrees. Have I done well-balanced unis in 5 degrees of varus? Yes. And they've done very well? Yes. And there are plenty of total knees that are well-balanced in 5 degrees of varus that have done very well based off Pagnano's work out of the Mayo Clinic. So I think constitutional varus is a hotly debated topic and more common now. It was always common in unis. It's more and more common in total knees. But I use robot and navigation to confirm where that is. But you could do it the old method by preoperative templating as well.
Lovely. Thank you very much, Anil. Thank you very much. And, if you have to leave, that is fine. If you're most welcome to stay back and, listen to the other talks. So can I now, if you just stop sharing your screen, Professor Greichen can then start doing that, please.
Stop share.
Yes, please. So we have now Professor Greichen, who is going to talk to us about results of unicompartment knee replacement and reasons for failure. Prof.
First of all, thank you for inviting me, giving me the opportunity to get in contact with the Indian surgeons again. So I miss it during the pandemic. Normally I come to your country 2 or 3 times a year. This time only in virtual reality. So let's talk a bit on unicompartmental arthroplasty and the results. So we heard from a real specialist how the special results are, but if you look at it nationwide, it's not that phenomenal like we heard in the last 10 or 15 minutes. So I want to look a bit on average results, and I want to spend some time also on the reasons why the result is maybe not that optimal, and also spend a bit time on solutions, how we can improve outcome. So this is registry data from Total Knee. And if you look at that, then you see that after 10 years, you have a revision rate that differs between 3 and 9%, depending a bit on the implant. You do the same registry, same 10-year data for unicompartmental, then you see now it's between 6 and 27%. That depends a bit on the uni design, of course. So the one with the 27% has a real problem with the tibia fixation. So I think this one is withdrawn from the market some years back. And the same company presented now another fixed bearing design that excellently works. So that's the one with the 5.9 after 10 years. And then the number one in class, which is the Oxford, has around 15% revision rate after 10 years. So if you compare that to the Total Knees, we still have to ask ourselves the question, why a uni? And there are a lot of arguments that comes from the limitations from Total Knees. So patients' expectations, and we heard about that in the talk before, we are not able, even if we are the experienced surgeons in the world, we are not able to fulfill the patient expectations in 100% of the cases. And this is a Scandinavian paper, almost 10 years old, and you see that they have reached their activity goal, the patients, only in 14% of the cases. So that is real the data which is leading us to other implant options. And then you're automatically coming back to unis and patient satisfaction. There's a lot of published data on that it's a lot higher compared to Total Knees. And as Dr. Ranawat said, it's not as high as in a hip, but it's a lot higher compared to Total Knees. And the patients, they love their uni also because of the shorter rehabilitation time, shorter hospital stays. There is a very much reduced post-op morbidity. And then in the long run, the improved satisfaction, they are back to higher activity levels. And also their gait pattern is a lot more physiologic. So a lot of arguments why we should do a uni. What determines the long-term outcome? And there are, I think, 4 very important factors, and I want to touch them in the next 10 minutes. So outcome factor number 1 is the experience of the surgeon. And the talk before was from a very experienced uni surgeon. So, and if you look at the literature, then you see that the expert studies always present better results compared to the registry data. So in the registry data, after 10 years, you're around this 15% failure rate. In the expert studies, you're around 10, in some only in 5% of the cases. So that made the authors of that paper find a borderline. So you should do at least a minimum of 20 unis a year to get good results. And if you see a percentage of around 10% of your total knees be in a uni, then you should do around 200, 250 total knees to become 20 to 30 unis a year. So that's the number that you should have in mind. There's another nice paper on that. That's from the Norwegian Arthroplasty Register. They also looked at the effect of experience, and they divided their groups into 4 different groups: less than 10 procedures, between 11 and 20, 21 to 40, and more than 40. And what they found is that the relative risk for an early revision is double the time in low volume centers compared to high volume centers. And then they looked at the reasons for that, and they found technical errors. This is what we heard. Maybe we can solve that problem with the help of the technology, but also wrong indications. So those are the reasons why the low volume centers finally have not that good outcome like the high volume centers. So reason number 1, as I said, is experience of the surgeon. Reason number 2 is find the right patient. So the old indications, we have seen that in the presentation before, they're going back to the late 80s from the last century. So, but they are still there. So medial arthritis, intact lateral compartment, patellofemoral, almost no symptoms, no rheumatoid patients, intact ACL, PCL, free range of motion. Nowadays, they changed a bit, and I will talk a bit on that in the next 2 or 3 slides. So what about age? And I think it's there are 2 groups. It's the young patient group, and then it's the very old patient groups. They get their last implant with the uni. So as in all the implants, of course, the younger the patient, the higher the revision rate. That's the same for a uni or a total. But the patient satisfaction in the young age group for a uni is so much higher compared to the total that it's definitely a good consideration to use a uni in this group. Body mass index, complication rate, of course, is higher in the very obese patients, but the aseptic loosening rate is not dramatically higher. So that's, of course, for BMI less than 35 or 40. For the group with a BMI of 45 or 50, you should not consider a uni. Maybe you should not consider a total. What about the cartilage wear? Yes, we have the ideal indication here with this anterior medial third and an intact ACL, but there are also some other areas where you can have a bit of an arthritis, so of the lateral compartment to the intercondylar area, or if you look at the patella on the medial facet, it's not a contraindication. What about the ACL? I also use a fixed bearing design, so it's not a contraindication per se. You have to look at that clinically. So if it's just an AP insufficiency, then as you have heard, reduce the tibial slope and the problem is solved. If it's an additional rotational insufficiency and it's a very young patient, then you can combine a uni with an ACL reconstruction, but that is very rarely the case. And in all the older patients, for me, that's a candidate for a total. One very important thing in my pre-op algorithm is looking at the different angles of your knee. So the MPTA, the medial proximal tibia angle, which is not 90, it is 87 in most of us. should be in a range between 85 and maximum 90 to do a uni. If it's more than 90, you should not consider a uni, because this will not end in a physiologic axis. And if it's a lot lower than 85, it's very difficult to correct. So we have this normotype, which is this 85 to 90. Everything comes from intra-articular in this, and that's a good candidate for a uni. Then you have the hypervarus type. They have an additional extra-articular varus deformity, so you cannot correct everything within the joint, and you should not do that. And then it depends a bit on the amount of extra-articular deformity you have. If it's only 2 or 3 degrees, that's not a problem, but if it's more than 5 degrees extra-articular, then it's not a good candidate for a uni. And then you have this hypovarus type. As I said, if the MPTA is larger than 90, then you're in high danger of overcorrecting the knee, and this will end in revision very early on. So my ideal indications for a uni is this unicompartmental disease. They should flex more than 110, the FFD not more than 10 degrees, MCL, LCL intact, ACL clinically stable, and the MPTA between 85 and 90. Not too fat, not a lot of additional other diseases. And then careful pre-op planning, I think, is important to get good results. But it's also important to talk to your patients about his expectations, and we should inform him on the higher revision rate and increased risk of earlier loosening. So surgical technique is factor number 3. So we heard a bit on that, so I don't want to talk too much on that, but that's a list from the literature. So reason number 1 is overcorrecting of the leg axis. So if it's a uni and your HKA angle is here, then you have overcorrected that knee. And that's not a perfect solution. So you should leave it maybe in 2 or 3 degrees of varus, as you have heard in the talk before. But you also should not leave the tibia component itself in more than 3 degrees of varus. Otherwise, also there's a high potential for failure. Also, if you increase the tibia slope, so here this tibia slope now has 15 degrees, that's far too much. And you see also the posterior aspect of that tibia is not covered. That's another problem of this tibia component here. And another one, if you produce an overhang on the medial side, then you have a stress on the soft tissue all around. That is also a surgical mistake that should be avoided. Implant design, maybe it is a factor, but that's not so clear. Depends a bit on the literature you read. So there are a lot of studies showing no differences between fixed and mobile bearing. There are some others showing that there is a difference. And if you look at the NJA report 2018, there is a difference between mobile bearing, which is the Oxford here, and the fixed bearing here from Zimmer, but nowadays you also have the J&J results, fixed bearing. So after 10 years, the revision rate in the fixed bearing is lower compared to the mobile bearing. And you also find that in Australia. If you look at the Swedish register, you don't find that difference. So as I said, it depends a bit on the literature you read. The disadvantage in mobile bearings, you're all aware of that, is the problem of spin out, especially if you do it on the lateral side. That's a bigger problem. Factors for improving it, you heard on that. There is technology on the market that really makes this surgery more precise. So you have navigation options with pin-free navigation, with full navigation, or nowadays the robot, which is more or less still a navigation technology, but of course an advanced one. And this is proven also in some papers, and you have seen that in the presentation before, that technical precision is reducing the risk of complications. And I think this, in the long run, will improve the outcome of unicondylar knees. So to summarize, at the moment, the long-term outcome of uni is not as good as total. Especially the correct indications. So take your time, find the right patient. And if your volume is less than 200 total knees, then maybe think of starting your uni career. You should have at least 20 unis a year to reduce the risk for revision. Your surgical technique must be reproducible and precise. And I think modern technology can help us with that. And at the moment, if you look at registry data, fixed bearing seems to do better than mobile bearing. Thank you for your attention.
Thank you. Thank you very much, Prof. If you please stop sharing your, there we go. Sorry. Right. So any questions? Anyone? We've got time for a couple of minutes.
Rashid, I think Dr. Bhinde had a question, but I couldn't understand his question actually.
Okay.
Harish, if you can.
Yeah. Can
ask you.
Harish? Yeah. Can you hear me?
Yes.
Very well.
Yes, Harish, we can hear you.
Yeah. The question is, if you have a 55-year-old guy and he has a unicompartmental knee arthritis, but not the ideal indication, slightly extended, maybe a little more deformity or little more, bone loss, would you still like to do a uni, wait for 10, 12 years and then convert it to TKR at the time he's maybe 70? Or would you go for, because we know that 15 years is by that 15 years, they may require a revision, or you should go for a primary good TKR, which should last for about 20, 25 years.
Prof.
As always, a good question, Harish. Thank you for that. I think it depends on a lot of factors. So your summary of the patient was very short. So 55, definitely age is always a factor. But as Dr. Ranawat said, pick the young ones or pick the very old ones. So it is the starting implant or it's the last implant. So for me, the more problematic ones are the ones that are 65. Then I really think about it. So 55, lot of deformity. Then I would look at my angles. If the deformity comes all from cartilage wear and bone loss intra-articular, I still think a lot about unis. But if there's another component with extra-articular varus coming from that side, then I would think about HTOs. So I think it's not only always a question between a uni and a total. Once in a while, it's also the question between a uni and an HTO.
Yeah. Okay. We normally tend to forget H2 as an option as an arthroplasty surgeon.
Yeah, right.
Okay. Can I ask one question?
Yes, please.
Yeah.
Mostly.
What is the oldest patient you can do UKR, and what are the specific clear indications for elderly patient for UKR?
So for me personally, age per se is not a contraindication, and I pick a lot of 80-year-old patients, but my patient is different than yours in India. So you have very soft bone, even in patients that are 60. My bone is very hard. So I have old guys still gardening. They have bone like I have. So that's not a problem. So bone quality in older patient definitely is one of the main issues. I'm hesitant to do a uni, so check that. And if you're in doubt, go for the total, because that uni will fail. I think that's the main difference between an old patient and a younger one.
Prof, you told that if the ACL lacks ACL, then probably fixed bearing is a better choice compared to mobile bearing. But non-functioning ACL is one of the contraindications for uni. How do you explain it?
I try to answer that in my talk. I think it's a bit difficult. So as also Dr. Ranawat said, so there are a lot of ACLs that are maybe not functioning perfect, but if you put in a fixed bearing uni, they're still good enough, and those patients are more happy with their uni compared to a total. So I think you don't have to have a perfect ACL to get a uni. And if you're really in doubt and you have a fixed bearing uni, then maybe you reduce the tibia slope a bit. And by that, it is also solved.
Okay.
Can I ask a question?
Yeah.
Yes, please, Anil.
Yeah, that was a great talk. Professor Hagi, how would you say in Germany has been the Oxford experience? You know, a really interesting debate, which we'll get later, is, you know, fixed bearing versus mobile bearing. It seems like you're more of a fixed bearing guy. I mean, I've seen a lot of mobile bearing growth in India. My experience was in the US, or the US experience was 10 years ago, Oxford heavily marketed it. Every inexperienced sports surgeon, not really arthroplasty surgeon, said, oh, 99.9%. Who's not going to want that? Everyone did Oxford, and we had the highest failure rate. And so just an implant without proper indications and technique is never a good idea. And I see that a little bit in India. What is the experience in Germany and in Europe with the, what's your take on mobile bearing? Let's say not Oxford, say mobile bearing.
We have I think the experience in Europe is a bit like you said in the US. So there was an excellent marketing from the Oxford guys. They had extremely well organized educational courses with learning centers and everything. That concept was really good, and that brought the market share of Oxford in Germany to more than 60%. But that is around 10 years back, and now a lot of this hype is gone, and there's a strong shift from mobile bearing to fixed bearing. I think it's not only just because fixed bearing is more forgiving. I think also now we have learned that the indications the guys from Oxford told you, they are I think too extreme. So it's as always, as I said, it's not only the implant, it's also the right patient and the right surgical technique. This has to come together. And I think if I look at my percentage, it's constant between 12 and 15%, all the last almost 10 years now. And fixed bearing, I also moved from mobile to fixed bearing, both a lot of.
Yeah, Anil, I was at the American Academy. Hello.
There's some disturbance.
Yeah. So, Anil, I was at the American Academy in 2004, and I heard this very nice lecture by Richard Scott, and he said, like, before I couldn't get the Americans to do uni, and I know I can't stop them from doing it. So, and I think your result, what you're talking about, is from that fad which came on, like everybody had to do it, otherwise you are not an arthroplasty surgeon, actually gave a very bad results to many of the unis which we are now seeing coming up. And at that time, unfortunately, the uni which they were all talking about was Oxford. So Oxford did get a bad name during that time.
Right. Okay.
Can I? Is there any indications since you are doing more of fixed bearing? So, is there any indication where you would like to choose mobile bearing uni in your this thing? What are the, or you straightway go for the fixed bearing now?
No,
I think we have a lecture.
Kamal, you'll have to wait for the next lecture, I think.
Next lecture.
Right. Okay. So let's move on. Thank you very much, Prof. Rajput and Anil Ranawat. I think so. We'll we'll get on with our program. So next talk we have is to decide whether we want to put a fixed bearing or a mobile bearing knee. So none other than Dr. Rakesh Rajput is going to speak about this particular topic, and then we'll see who wins the debate?
Yeah, thank you, Ashit, for asking me to actually come and speak on this. I would have been very happy to just present the case, but I think this is a very difficult topic because, as you heard from the previous speakers, you actually start. It's like a philosophy, almost like a religion. You know, you believe in something and you feel that that is the way to go. And I think we start talking about my religion is better than yours. It shouldn't be like that. Let's look at everything. I think, and let's start about how we actually divide this debate. And I think what I have done is believe that this is a different school of thoughts. Okay. And we are trying to achieve the same result. And if we talk about longevity and function, that should be the prime indication for all our surgeries. And let's look at some of the literature, what's it trying to talk about. Now, if you talk about longevity of the actual designs we're talking about, mobile or fixed, you name one uni design which is fixed bearing, which has lasted last 30 years. And the answer is none. You know, the real answer is none. Well, some of them did last 10 years, 15 years, went out. Like even Zook, which was so successful, as we mentioned in the literature before, you won't get it anymore. And now the preservation, which according to, I think was Dr. Greitchen's paper, had 25% failure rate at the Australian registry. Again, went out of the favor and Sigma partial was launched. So all these fixed designs, whatever you brag about, don't seem to last. You talk about the mobile bearing, and when we talk mobile bearing, let's stick to Oxford because none of them otherwise truly has been a mobile bearing. It has lasted for donkey's years, 40 years almost survival rates, or at least the design has lasted. So that will tell you one debate about the longevity, I think, is dead and buried. Now let's talk about mobile bearing. Are all of them same? And the answer is none. I think all literature, when we talk about mobile bearing, are all coming from one single unit in England. So why did this all actually started off? Because when they were trying to design their uni knee, and if you go back to the Oxford history, actually it was a duocondylar knee. It was just one of the very nice anecdotes what happened and why it actually ended up with Oxford. It's a very nice story. We can probably discuss that story at the end. But at that time, they were talking about three functions of a meniscus. You talk about congruity, which it maintains. It gives you mobility, and it gives you a meniscal compliance. Now, if you want to add as much function as possible inside your unicompartmental knee, you can understand that it's not going to come with fixed bearing. So their original design was a mobile bearing. Now let's talk about what happens if it was not. And again, I'm going back to the designs which were there. I'm not going to talk about current designs, because the data isn't there as strong for 10 years and 15 years. Where we know is going to be inescapable if you're going to be a fixed bearing design. The polythenes were thin, and what happened with that was the failure was very common. And that is why if you look at the Miller guarantee knees, the link knees, they were all actually going out of favor. And what happened with the Oxford studies? Again, we have to go back and talk about mobile bearing studies from Oxford because that's where the data is. If you look at the fixed bearing designs, which is on the left of the diagrams, mobile bearing right, whether you look at the heel strike, you look at mid stance, you look at tough, and you'll find the yellow is actually pressures which are more than 20, which is not good, which is quite a lot. And you can also see the concentration of that pressure on one single point. Just let me know if I'm audible because my internet connection, I think, is getting a bit weaker. So if you look at the mobile bearing and all these three phases, well-distributed pressure and well within the tolerable limit, which is the blue color. If you also retrieve the designs and you actually look at the wear, particularly for Oxfords, you will design a well-functioning Oxford. The wear rate is going to be 0.03 millimeter per year, which even at 10 years is 0.3. Which is hardly negligible. So what they did with this design was they took the wear rate out of the equation. That didn't really happen with the bearing. So if you have a retrieval studies, this design can be done. What was found with this was that if you have impingement, and I think it's very important point, which now even the fixed bearing people have started using the same concept. If you have impingement, and what we're talking impingement predominantly is when you actually extend the knee at the tip of the where femoral implant is that coming into articulation with the poly. Now, then you have a very catastrophic wear rate, even in a mobile bearing knee. So if you have impingement, the wear rates are very high, so you need to get rid of impingement. So that will be equally true for many other knees also. And if you look at the data, I have plenty of papers here which will tell you that the Oxford scoring slightly higher. So you can easily go and look for the current papers which will tell you the fixed bearings are trying to score a bit higher. I'm trying to be as neutral as possible though here. And I do both of them. I can assure you that I do both mobile and fixed bearings. So if you look again at the kinematics, there is this anterior translation, which is supposed to happen along with the meniscus, does happen with the actual Oxford knee also. One other kinematics you need to look at is a sagittal plane kinematics. And here's what we talk as the patellar tibial angle. So the tibial tendon, which it makes the angle along with the tibial axis, it's very important because that's the force generator inside your knee. Remember, you are not going to replace the patellofemoral joint. So you need to have as near kinematics as possible. This study originally was done with TKRs, UKR at 5 years and UKR at 10 years. And if you look at the normal axis, which is this way, and if you look at the TKR, and as Anil also said, the TKR is never going to reproduce that same axis as which normal axis is. Now, does the UKR produce that axis? And I think it's quite likely that if you have your posterior cruciate functioning, if you have anti-cruciate functioning, the UKR almost resembles like a normal kinematic axis. Even if you look at the fixed bearing, I think the axis is deviated to some extent, but not as much as that, though the studies are a bit weaker. And even at 10 years, as long as you have the cruciates which are functioning, and that is why the importance of cruciate ligament has been discussed so much already by the previous speaker. If you have cruciates, even at 10 years, and I'm sure even at 15 years, it will probably remain the same. So cruciate working is very important. Doesn't matter what function, what activity you're doing. Now, what happens with stress? And again, these are all biomechanical studies. You already have a concave, convex femur, which is articulating in a concave tibia on the proximally on the articular surface in a mobile bearing design. And if you look at that, when something moves here, there is nothing stress which is impacted at the base plate and the bone interface. Whereas if you have a fixed bearing design, it will actually impart some forces out there. What happens with time? These forces will start creating a bit of dent. And if you look now, the two things which are looking in front of you, what you see, the fixed bearing is almost going to resemble almost like a mobile bearing, the actual articulation design type. So the wear rates are very much in the center of it. So what happens with this wear rate? The loads which are going to be transmitted across the base plates are not going to be uniform, which happens with so-called fixed bearing, mobile bearings, but it's going to be on a single stress, and that causes loosening of the femoral base plate. Now, these are all biomechanical studies. Clinically, the designs may be very different. The fixation techniques may be so good with fixed bearings, it may actually be overtaking and overcoming all these problems. So the one thing I was talking about, Oxford design from 1976, if you look at the basic articulation of a convex femur, single radii femur, along with poly, which is concave on the top, flat on the bottom, base plate, which is well inside the tibia, this hasn't changed. So this tells you that the way to put it has changed. It itself has not changed. And it has, if you look at fluoroscopy, I'll go a bit fast here, it hasn't changed. Now, again, coming back to ACL, we need to have some evidence here. If you look at the ACL, which was absent compared to ACL intact, you will start seeing almost the success rates dropping down to 67, 70%. Whereas with an ACL, you remain high 90s. So it's very important to have an ACL. And if you take your indications properly as an anteromedial OA, the survivorships are very high. And this is what the previous speakers were saying. The indications have to be picked very well. Now, this is an independent paper. We don't need to talk about the designer surgeons. Now, let's talk about a Swedish surgeon who actually went to Oxford, learned their trick, and not only actually had a good result, his results actually surpassed the results of Oxford. And when he was analyzed that why was he creating better results than Oxford, they realized that he thought about impingement, which the Oxford group still was not thinking. And after that, I think the impingement became an issue. This is, again, many surgeons you can compare about fixed bearings. Again, all fixed bearings are not same. Some of them are disaster and some of them are reasonably good. So let's come down to this criteria, which small amount has already been discussed by the previous speaker. The fixed bearing UKRs had a contraindication of patellofemoral damage, at very high age and very high level of activity, obesity, even chondrocalcinosis was considered a damage, and no amount of lateral damage was acceptable. Now, if you look at the same criteria with which they were actually a contraindication with fixed bearing in times gone by Cosin and Scott, the Oxford group did not believe these as a contraindication. So if you look at their success stories about, doing this, you realize that with obesity, they kept on doing, they had good results. In fact, they had probably better results with obesity than they had in a normal way. If you look at the other indications, they realize that all of the contraindications which so-called were for fixed bearings, Oxford group totally negated them and said, we have had no difference in overall success rates, even with these contraindications. So what happens with patellofemoral joint? What they actually found was that even though you may have some radiological changes, and particularly on the medial side, it does get decompressed when you do the actual medial patellofemoral replacement. So it itself is not. But if you have a lateral side serious patellofemoral changes and almost bone-on-bone contacts, then perhaps it will become a contraindication to that. So now with all this applied together, if you are trying to do a fixed bearing, and I'm sure like a lot of other people still believe in some of these contraindications, you will then talk about only 5% of your knees actually being suitable for UKR. You've heard Dr. Grachin saying that you need to have either 20% of your practice as a UKR surgeon, or you need to have at least, if you're a high volume surgeon, at least 20 of them you should be actually doing in a year. And I would say it's probably 30, not even 20. So you should be doing at least 30 UKRs in a year if you want to have results which are below, between 5 to 6% of failure rates at about 10 years. So that's and if you follow these criteria, then you aren't struggling. So I have never believed in this criteria, even when I was doing fixed nearing. In fact, one of my best success results have been in a guy who's 149 kgs, and I had done the old Dupuytren preservation knee on that. So if you apply these criteria and negate them, then almost 50%, according to Oxford, patients actually become suitable. Now, again, as somebody said in the back, that is a very high end and doing 5% over. And I think the proper indication would be somewhere between 15 to 20% in majority of our practices. I think what we see in India. Remember, our patients actually are already slightly varus, so we don't have that much of an issue. We may have issue with osteoporosis, but we don't have that much issue with actual, going into valgus, because our knees are actually quite bowed, and our patients are very suitable, even at a younger age, very, very suitable patients for actually a UKR. So in conclusion, I think, the debate between mobile and fixed bearing will go on. But if you look at from the academic point of view, the debate probably is slightly in favor of a mobile bearing, though clinical outcomes are slightly different. I will also bring into the registry data, I think, which both Amar and Dr. Grachin quoted. And I think this had set the cat amongst the pigeon. Oxford had to send their registrars, and even the England registry, the UK registry also was showing something similar. Then they had to send, and I'm very happy to tell you that paper also has been published, where they have actually negated all the findings of the registry, and the registry has accepted that probably were not right, their data which they were publishing. So, we should not even believe the registry's data blindly, and should probably look a bit deeper into those registry data before we make our own, set. I really liked what Anil just said, that robotic TCAR, I think, may change the way we have looked at UCAR in general and fixed bearing specifically. I think since the robots have come in, the huge thrust which is happening in a fixed bearing implants have really multiplied. And now a lot of surgeons who were initially reluctant are actually very happily talking about them. And I personally do believe that robotic UCAR may become the operation of this decade. And I think, let's mark this word, whether I'm right or wrong, but I think this decade will justify that. And I think, as I just said, it has helped many surgeons to jump ship, and it has also convinced many visitors. In summary, I think the debate is not really between uni versus TK. I think there's their own separate set of indications. I do not think even a 55, 65, 75, it is suitable. So every patient who walks into your clinic, you should look at this patient. Is he suitable for UCAR or not? Rather than saying, okay, I can't do a TCAR, or too young for a TCAR, or too old for a TCAR. That should not be the way we should look at these patients. We should look, will I be able to do a UCAR? If not, I will do a TCAR. That should be the way we approach from these patients, or even high T velostomy. I think I'm not totally negating that out. And we should be learning both these techniques and then choose the best one for our patients. Also, the patient profile may actually decide which one is the best for it. And we should do enough of this. I don't think, doing anything less than 20 really be justifying anything for this UKR thing. So this debate between, fixed bearing and mobile bearing will probably go on for some more time. And I think both of them will probably stand the test of time. So I personally believe, listen to this, come back and tell all your experience, what you've actually got through. And I personally really always feel, may the best knee win. Thank you.
Thank you. Thank you very much, Dr. Rajput. If you just stop sharing your screen, please, then we can get Dr. Bachani. Okay. Right, Dr. Bachani, you can start your, sharing your screen with us. Meanwhile, if someone has any question, just one question, probably we have time for one question for Dr. Rajput. Anyone, please?
Rakesh, what is your opinion about the ACL reconstruction concomitantly at the same time when you're doing a unicondylar?
Yeah, so I think if you find ACL deficiency, fairly okay for having a TCAR, just go and do a TCAR. Do not think about a reconstruction. Number two, if you want to do that surgery, you have to be good in both, or you need to have a soft tissue guy who's working along with you. The chances you are going to pre-operatively identify this is 1 in 500. That's a study which the Oxford group talk about. So 1 in 500 knees are going to be like this. And sometimes they actually ask, is this question worth actually to be even asking if it is going to be 1 in 500? So let's say that you do get it. In that case, I think if you got it pre-operatively, you need to decide what are the predominant symptoms. Is it instability a predominant symptom, or is pain a predominant symptom? If it is pain, go ahead with the replacement. If it is instability, reconstruct just the ACL for them. Many times the actual pain disappears. Whatever mild pain they have also disappears with ACL reconstruction. If you feel it's a touch and go situation where both are predominant, yes, there are techniques where both can be done. You can do an ACL reconstruction along with a uni. It is not an operation I would suggest for a an average surgeon, I would say.
All right. Thank you very much, Rakesh. So can we start with the presentation from Dr. Bachani, who is going to talk to us about mobile bearing knee replacement, mobile bearing UK. He has been doing it for quite some time and has got a large series with a good follow-up of about 10 years plus. So Dr. Bachani from Columbia Asia Hospital, Gurgaon. Over to you, Kamal. Unmute yourself, please. Unmute yourself.
Can you hear me now?
Yes, very well.
Yeah.
Please go ahead.
Yeah. Thank you very much. I would like to say thanks to Dr. Rajput. He has already covered a lot, half of my presentation, and made my job very easy by talking about the mobile bearing unicondylar knee. So I'll just basically go ahead.
Please click on the screen.
So, like it has been, lot has been talked about the registry data, and we have seen that even if the survivorship in the case of total knee replacement is more than 90% at 10 years, but unhappy patients have been reported to 20 to 23% in the various kind of registry. And what is more surprising is basically when we talk about a lot has been talked about the earlier has been talked about the poor results of the UK in terms of revision criteria. And it was a paper in 2010 was published where it was analyzed that UK have a lower threshold for revision than in case of TKR. And it was found that if there's a very poor outcome in case of TK, only 12% are revised. Whereas in the case of UK, 63% are revised because it is very easy to do so. So that's what I think the crux we have to really analyze the registry data also carefully. Now, a rationale of UK has already been given. Why I'm talking about basically anterior medial arthritis of the knee in early phase of the arthritis is incapacitating. And if it is left like this to pursue a natural course, it will result in progression to the other compartment. And like somebody asked the question of about if there's a ACL, degenerative ACL tear is there. So I like rightly mentioned by Dr. Rajput, what we have learned that if the medial arthritis is left to pursue its natural course, it will go to the intercondylar area and results in basically instability, incompetency of the ACL. So that's an indication that the forces are already progressing to a significant extent. So in that case, I think it will be a degenerative tear of the ACL would be probably better tackled by other procedures than kind of UK, what I learned. And the proven record of the implants has already been mentioned by Dr. Rajput also, various studies he has shown. And 15-year and 20-year survivorship has been mentioned in the literature also. Now, why mobile bearing UK basically? It optimizes congruency and minimizes the point tibial contact forces, which are very well enumerated, and stress at the implant fixation interface. And it has got because of the constant radius of the femoral implant, as well as the non-constrained insert with the intact ACL, there is a rollback mechanism is there even with the presence of the cruciate ligament, mimicking the normal kinematics of the knee, as well as reducing the wear rate of the poly also. These are the other data which were basically analyzed, and somebody asked this question in the, I think Dr. Binde, that what if there is patients who have undergone TKA as well as UK. So it was found that higher proportion of patients having undergone PKR than TKA would have chosen the procedure again. And in terms of better functionality and more natural gait, we have already talked about. Does helps in faster recovery and shorter hospital stay, which was mentioned in the earlier presentation also by the professor, is one of the reasons why it basically is more sort of fancy to choose also. And there is a better return to sports. And moreover, the UK has a reduced overall risk of post-operative complication. At least this was mentioned in this trial studies also compared to TKR. There are other varieties of the mobile bearing which are available this thing, but we do have a limited experience besides of mobile bearing other than the Oxford. So I'll be talking about the Oxford only. In our faculty, I'm sure there are other surgeons who have tried other kind of mobile bearing also, like Dipoe as well as Escolab. Maybe they can talk about, but I do have, in case of mobile bearing, I do have a experience with the Oxford, so I'll be talking about that only. The commonest complication and revision reason in mobile bearing UK basically helps us to basically plan also how our surgical technique also. The most common complication was dislocation in case of Oxford, especially it has been very well mentioned, especially in the early learning curve or a center where there is a low volume of the surgeries are being done. And the commonest kind of reason for revision is in mobile bearing UK is also progressive arthritis moving to the lateral compartment, although in some cases it may not be symptomatic. And like Dr. Ranawat also said, Dr. Amar said he sometimes inject also the lateral compartment. So this is also one of the reason, and he mentioned that he would like to keep the knee in slightly varus in order to reduce the overstuffing of the lateral compartment. These are the various series which are mentioning the survivorship in the mobile bearing UK. Almost close to 90% in almost all the series, at least at 10 years or so follow-up. And O'Connor said that the wear rate of the poly is 0.026 millimeter per year in a well-done uni. Regarding the surgical technique, I'll not go into the detail. Few important points which we have learned is adequate exposure. That means we need to see even though radiologically and clinically we have assessed the integrity of the functional ACL, but we need to see per-operatively also whether the ACL is actually functional by doing the tuck test with the probe, as well as should be able to see the lateral compartment. There should not be gross degenerative changes in the lateral compartment. Minor ulceration or osteophytes are acceptable, as well as in the pectorofemoral joint minor changes are acceptable indication for mobile bearing uni. Intramedullary instrumentation do help in producing the reproducible alignment in extension, and the anterior-posterior axis offers varus valgus alignment in flexion, and the femur has to be basically 10 degree of flexion and 0 degree. No extension of the femoral component is acceptable. We need to remove the osteophytes completely in order to have the ligament balancing, and avoid tibial over resection. This is one of the more emphasized part, that especially when you're doing a vertical cut, not to basically lift the hand so that you don't end up going too deep on the posteriorly. And when you are using the pins in order to fix the tibial base plate, avoid putting too many pins in so that when you are making a cut, the subchondral bone is not sort of violated too much. And we need to maximize the surface area, take the bigger tibia, but at the same time avoid more than 2 millimeter of overhang medially. Avoid recutting, and there's a inbuilt slope in the instrumentation of 7 degree in case of the mobile bearing, which I'm talking about, the Oxford. And when it comes to the femoral preparation, as I mentioned, we need to basically, it is designed in order to have 10 degree of the flexion relative to the long femoral axis and avoid extension of the component. There should not be any edge loading, and it helps in increasing the contact area and deep flexion. The femoral jig is basically attached to the intramedullary alignment rod with the case this thing, and it's basically varus valgus angulation of 7 degrees acceptable, and as I said, 0 to 10 degree of the flexion is acceptable. We need to, the 6 millimeter hole need to be seen clearly. It should be equidistant from the medial as well as the lateral aspect of the medial femoral condyle. And the narrow posterior bottom of the femoral jig should basically sit flush against the vertical tibia cut in order to avoid interference with the vertical wall. The gap assessment has to be done whenever you are doing inflection and in extension. You need to take out the gap, the spatula or the taper feeder gauze and put it in 20 degree of the flexion of the knee in order to see the balancing, and accordingly the milling has to be done in order to balance the flexion and extension.
You got a minute, Dr. Bachani.
Yeah, I'll just quickly go through. So this is like, as we have seen, the early results do show good kind of stability of the implant. And that's what we should be aiming to achieve for. And our study was basically had a follow-up from 2.5 years to 10.5 years, over 70 patients. Only those patients who had a regular follow-up were included. The patient on which the follow-up was lost, we haven't included. There were minor radiological evaluations, complications were noticed, which were did not affect the early to mid-term survival. Important thing is, in order to assess, we need to take the skygram properly in the lateral as well as AP, and standard X-ray is actually not good. These are the given in the Oxford criteria how to really assess the implant, and the professor also has mentioned in this lecture very well like what all criteria should be seen. I'll skip the radiological assessment. We had 95% good to excellent result in our case. This is a midterm results we are presenting. Complication results in our case series, there was unexplained pain in a significant number of patients, especially in the early phase, which usually settle down. It takes sometimes 6 months to even 8 months we have observed. Overstuffing of the joint we did notice, and as Dr. Anil Ranawat said, the way to go may be in future to use more of navigation. So these were the results in our early to midterm. That's what I want to basically present. Thank you very much.
Sure. Thank you. Thank you very much, Dr. Bachani. Just one question, please, we'll allow till the time you, Dr. Karthik Shukla gets, he shares his screen. Any question for Dr. Bachani, please?
How many times have you converted the UKR to TKR on the table? Or
yes, in limited number of cases, not too many. In fact, I can count on less than one hand fingers in my series so far. And in fact, in few cases, we were in dilemma. Whenever we are in dilemma, in fact, we would prefer to go safer way to TKR rather than make it an extended indication. Because in our case series, I suppose Indian patient, we want to do one surgery and that should give the right results. So that's what my philosophy is. So I'm not going too many extended indication, I would say.
Rakesh, can we leave it for later on? Please?
Okay, fine.
Okay, right. Okay. So up till now, we've heard about the technology, technique, and the implants. That is what is going to affect. But as Professor Grachin said, we have to have the right patient. And that's what Dr. Karthik Shukla is going to tell us. Which is that right patient who is an ideal one for a UKR? Karthik Shukla from Ahmedabad, Kedison Orthopedic Clinic. He is a senior consultant orthopedic surgeon there. Karthik, are you around?
Yeah, I am fine. Thank you. Good evening, everybody. Am I audible well?
Yes, audible, visible. Go ahead.
Okay.
8 minutes
I think,
starts now.
Okay. I think I'm not a right person to talk about this topic, because this topic specifically mentions selecting that ideal patient. So when that comes in the picture, this is the picture I have deliberately choose, like that ideal means once in 100, one in million. So if this is going to be the scenario, it is very difficult. So my journey of 8 minutes is to bring that to the ideal patient, because there are so many ideal patients. So if we further compartmentalize the UKR, there are two basic broad categories, because UKR is intellectually exciting procedure and as well as technically demanding. Technical part is a surgical part, and intellectual part is actually the right patient selection, and we are going to talk about this. So this is the journey we want to go through in 8 minutes. This is the topic given to me, that ideal patient or the right patient, and my perception is there are so many, 33 to 50% of patients, they are ideal, especially in our Indian scenario. Complexity always varies between the indications of fixed bearing uni and the mobile bearing uni. Over a period of time, there is more uniformity coming, but still the debate will go on about it varies or it remains the same. So in the COVID, we have understood the layers very well. So this is a very simple way I had designed, putting literature aside, very applied way or practical way to select the right patient. Filter the patient through 3 layers. Layer 1, is this a knee patient or is this a knee problem? Here we rule out the spine and hip. Is this osteoarthritis? That is the second question. And the third question is this anteromedial osteoarthritis? Let's learn it very simply. We all know how to rule out other pathologies coming from the spine and hip and the referred pain and radiating pain. So we are not going to cover this here. The second is the middle layer. Here we really definitely need to rule out 3 things, that is rheumatoid arthritis, any kind of significant inflammatory arthritis, a mechanical pain, which may be mostly acute in history. If you go to the history, it is acute pain, and the periarticular soft tissue pain. Here, one point is very important to be noted is if more than 3 millimeter space, it is not a bone-on-bone arthritis, don't do UKR. It's definitely going to have poor results. And in other way, as Dr. Ranawat has rightly mentioned, the bone needs to be sclerosed. It is sclerosed only if it is bone-on-bone arthritis. So now at the end, we have clear picture that this is osteoarthritis. Now we start our journey to understand how it is anteromedial. Previously, we had been told about the degrees, and I don't think any doctor is good in remembering the numbers, otherwise they would have become the chartered accountants. So varus, we really don't know how much varus we need to accept. Flexion deformity, how to measure. Hardly we measure with the goniometer in busy OPD clinics. Weight, can anyone guarantee the weight will not increase after the patient will go for UKR? So it is not rational. Activity level, how to determine the activity level? This is a highly active patient or moderate active patient. And is there any possibility that the patient may be active after surgery or will be less active after surgery? No one knows. And tibia vara definitely added a new confusion to the things. So this is more anatomical criteria, which has been scientifically studied well and come up with a more physiological criteria. Like a surgeon, we can understand it very well. So no numbers, no confusion. Forget the numbers. We don't need any numbers. Number 1, pathology, better understand the pathology. And it has to be documented by very simple radiological investigation. At the same time, you have to confirm the preserved anatomy and the wrong contraindications are rectified. So these all 3 are anteromedial osteoarthritis, the varieties of anteromedial osteoarthritis, because it's a journey. So 10% is mild, 20 to 30% is moderate, and 10% are severe. Still, they are all anteromedial osteoarthritis. So it's a spectrum of extension. And medial compartment arthritis does not mean anteromedial osteoarthritis. This is just a physiology in short. We all know that very well. Again, just to revise, dead lateral X-ray is must. Once the cartilage is gone, this is the gap. When the patient stands, it gets collapsed. There is a varus. We appreciate the patient will himself or herself will come. So I have a bow leg. My legs are getting bent over a period of time. But what happens? The nature helps when they flex their knees, there is a rollback and the MCL again gets stretched. And that's why we term that flexible varus. This is the thing, only thing you need to see on clinical examination, the flexible varus. But if it is not treated well at this time, there is ACL involvement, there is a roll back of the femur. So the distal femur erodes the posterior tibia in extension, and that posterior tibia in flexion erodes the posterior femur. And then now it becomes a short fixed deformity with contracted axial. And this is not a good indication for unicondylar knee replacement. So the simple facts we understood out of this at this stage is anteromedial osteoarthritis is equal to good ACL is equal to flexible varus. Very simple. These are interchangeable words. You can speak AMOA, you can speak flexible varus or a good ACL. They are all same. No degrees are there to be remembered. Now this is a simple way or algorithm to go for X-rays. Not a lot of X-rays are required. Let's start the journey of X-ray, that is integrated radiology. Start with the AP standing X-ray. This is just a practical guideline what we all are doing in our OPD. So if it is a standing X-ray with bone-on-bone arthritis, the job, one part of job is done. If it is not bone-on-bone arthritis, then we definitely need to see whether it is bone-on-bone or not. Then we will go for a varus stress views. If it is not bone-on-bone, it is not a UKR patient. Again, if it is bone-on-bone, we come back to the same bone-on-bone. This bone-on-bone has 2 possibilities, either with tibial translation or without tibial translation. If it is no tibial translation, UKR is definitely, we are ready to go in. If it is tibial translation only, then we will go for the valgus stress view, and we will see if it is correctable tibial translation on valgus. If it is okay, then you go for UKR. If it is not correctable, it is not a UKR patient. Very straightforward in AP views. Now the most important comes is the lateral view. This is the lateral view, very easy to understand. One is right, one is wrong. If your posterior tibial cartilage is intact, you can go for uni because there is a good ACL. And the B picture you can see is the ACL deficient knees, a big no for a UKR patient. So lateral X-ray must be of good quality, overlapping. You can go in fluoroscopic investigation as well if you are not happy with your radiologist. This is type 1, we see good ACL. This is again type 2. Here the defect can vary up to any extent. So that's not a problem. The most important thing is posterior aspect of the tibia, which should be intact with normal cartilage, bad ACL and bad ACL, the subluxated tibia. So that is done. That is lateral X-ray. As already mentioned, patella is always a concern for lots of surgeons that patella is inward. Patella has to be inward. It is a varus, so it is not a normal tracking. If it is medial or lateral up to certain extent, it's fine. If it's a bad patella, and then it's not going to make sense to go for, because mostly this is seen in extreme arthritis or inflammatory arthritis. The pain initially was a thumb test. We don't rely on thumb test anymore. This is a paper showing the distribution of pain in medial compartment osteoarthritis, patellofemoral joint pain. It varies anteriorly and posteriorly with a bizarre picture of pain, and we don't trust. But if I go back to my patients and see, the reparative gesture of uni is best appreciated by patellofemoral joint. It really cures the anterior knee pain. So, and second thing, people are concerned with osteophytes. See, why we are concerned with osteophytes in patella? This is not a ligament balancing we are doing in the patellofemoral joint. It doesn't require your ligament to be balanced. There is no ligament. So just ignore the osteophytes. There is no need to remove the osteophytes around the patella if it are adherent. If it is free, you can remove. We had tried both and with the equal result. It doesn't make any difference.
You got a
so
minute.
This third, pardon?
You got a minute now to finish, please.
Yeah, this is the third layer. This is to confirm. We have confirmed this is enteromedial osteoarthritis. And as AMOA has a spectrum, I cannot cover everything in this, but I will go through a few cases. The obesity rightly mentioned. But this lady has promised me that she will go for a bariatric surgery after, because her knees are bad. We had operated her. She never gone for a bariatric surgery. And this is another patient we had operated, just showing the right position. If you want to do, this is OTP technique. We'll skip this. And this is the lady, she is doing it 6 years. She's a dance teacher. She had never gone for bariatric surgery, and I'm really afraid, but she breached her promise, and she is doing great at the 6th year with the bilateral Oxford. This is another example to mention. This is a SONC, spontaneous osteonecrosis. You can easily do. This is rare tibial spontaneous osteonecrosis of the knee. And this is almost 4 or 5 years follow-up. Flexion deformity, what causes the flexion deformity? It is the anvil osteophyte. And once you remove this anvil osteophyte in front of the tibia, you can get away with this. Stiff knee, this is an interesting patient we had because there is a big anterior osteophyte, big posterior femoral condyle osteophyte, 90 to 100 degree flexion. And once it is done, he had a full flexion. He's able to even sit cross-leg as well. So ACL deficient knee, we already had a discussion. Dr. Rajput has already mentioned. We had 3 patients, young patients, very young patients, 40 years around, and they had neglected post-traumatic ACL with both pain and instability. So this were done, and this is almost 5 years follow-up. The patient is doing fine, but this is a very rare. This is one extreme example. We had operated almost 6 to 7 years back. Everything, whatever you say is a fixed, means the TKR. This is what we also thought, the TKR. Young, obese, short stature, lateral thirst, tibia, vara, and whatnot. And she is having bad knees, very bad knees. And if you see the x-rays, this has to be TKR patient for me as well. But we thoroughly evaluated this patient because she is very young and she is very demanding. And if you see the lateral x-rays carefully, there are already posterior tibial cartilage intact in both the sides. Right side, we were more skeptical about than the left side. So we see this is the perioperative picture, and you can see this is the excellent ACL we had demonstrated with the hook, strong ACL. And this was the minimal tibial resection. These were the postoperative x-rays of the uni, and she is almost doing everything, sitting cross-leg, dancing in like a normal life, and she's a very happy patient. So absolute contraindications are just rheumatoid, post-traumatic, severe stiff knee, infection, involved lateral compartment, severe patellofemoral joint, arthritis, and incompetent ligaments. This is the big no. This is our series, 8 years follow-up, 1400 patients. Youngest is 38, oldest is 92, most obese is 135. This is our data of showing the unhappy patient for the complication is 0.0056 patients out of 1400 patients. One stiff knee required arthroscopy. One patient got infection. We lavage it, changed the poly, and the patient did well. One patient, female patient, converted to rheumatoid. One tibial fracture, and 3 bearing dislocation. 2 were traumatic bearing dislocation. 1 was not traumatic bearing dislocation. And 1 patient had anterior knee pain. We had to do a small procedure for the lateral patellofemoral impingement. So our total complication rate was 0.0056 at almost 7 to 8 years of time. So here, medial compartment arthritis. Yeah. As just to finish, it is done. So uni precisely corrects the knee deformity, hence it cannot be overcorrected. Select your right patient. Complete radiology is a spoon feeding of non-palatable food. MRI is just a self-inflicted wound, best if avoided in class of bone and bone. There is nothing like on-table decision. Select a right patient every time. And UKR is a repair, not a replacement. Simple things need simple understanding. Thank you so much.
Thank you very much, Dr. Shukla. Thank you. That was an excellent presentation with good follow-up of the series and with few complications that you came across and slightly extended indication. So because we are running short of time, I think so we'll move on to the next part of our webinar. We'll go back to our case presentation, and the first case is from none other than our incoming president, Dr. Rajiv Sharma, who is going to talk about one of the cases. Dr. Sharma, as you all know, is senior orthopedic surgeon, is chairman at Institute of Orthopedics and Joint Replacement Surgery at Mulchan Medicity Hospital in New Delhi. So can you share your screen? Dr. Shukla, can you stop sharing your screen, please? Right, there you go, Rajiv.
Thanks, Ashit.
7 minutes. So we all have equal time.
Yeah, okay. It's a pleasure to be with you all again. With excellent faculty. I'll be talking about the some complications of the unicondylar, though we have seen wonderful cases. We have been doing the unicondylar surgeries for quite some time. Like we see here, the surgery which was done somewhere around 2006 or 7. Other indications, the old DPU PFC preservation, which is now no more, which has been taken off, but it has given good results in many cases of ours. Mobile bearing joints, also the same. The Oxford Uni, it has a wonderful result. But what about the problems when you are doing the many surgeries of Uni? The peroperative fracture is probably one of the most annoying complication, because all the onus goes on to the surgeon. Now, I'll show you one of the case which we did recently. The patient, the surgery was excellent. And when we were inserting the poly, the assistant gave a small hammer to adjust a little bit, which probably should have been avoided. And what we see here in this patient, the hammer was at this point, and we see that there is a collapse on the lateral part. And fortunately, what we see is that the lateral cortex, the medial cortex, was intact. So it was kind of a incomplete fracture, fortunately, one of the first in all the unis that we did. But since this happened, what is to be done? Probably a plate is a good option, the proximal tibial plate. But because we did not have the plate at that time ready with us, so I had to do with the screws. And that's what we see this patient. We fix up the 3 screws, and taking the advantage that the lateral condyle, the medial cortex, was intact, and this was probably kind of an incomplete collapse. At that point, I kept the patient non-weight bearing and fixed up with just the 3 screws and a knee immobilizer. And we see that what should be done in these patients. The tibial cut should have been probably 2 millimeter less. The deep vertical cut should have been avoided. I think maybe it was a millimeter more, and no hammer to be used, or if at all, it has to be used very carefully. So that's one of the very unfortunate complication, but it can happen. And on the table, if it happens, probably the screw fixation, and preferably proximal tibial locking plate is a better option. So over to you, Ashit.
Sure. Okay. Excellent. So, any questions? Yes, please.
Yeah, Rajiv, when hammering was done, then it has fractured. There is no instability. You fixed a screw in situ.
No instability. We maintained. I just stopped everybody and just made sure that there is no more pressure is applied, no more disturbance is given to the knee, and just we fixed very small percutaneous. We fixed the 3 screws from the medial cortex.
Did you mobilize immediately or
not immediately? We made the patient wait for 2 weeks, and then after we started. This X-ray that we see is 2 weeks at the 2 weeks post-operative.
Right.
Okay.
We are keeping the patient non-weight bearing totally.
Rajiv, the reason for this is not just the hammering; it's also the the vertical saw which we go through.
Exactly.
So that saw actually sometimes inherently goes on if you don't have a block, and that's why now if you see the new jig even in the mobile bearing Oxford, it has got a block, so you can't actually go down.
Yeah.
And also before we used to cut 4 or 5, even Oxford used to come till 7 inserts. But now I think 4 is the maximum you would go. In fact, 3 is what we are all aiming for. Okay. And I was hearing Chris Dodd sometime back where now they are actually taking 1 away from femur and only doing 2 at the tibia. So that may be the way forward to prevent all these complications. Also, if you come down 3 to 4, you start generating hoop stresses. And that's the reason for medial pain lasting up to a year almost in these cases.
Right. I think Rakesh, you pointed very rightly, and we have mentioned here that deep vertical cut should be avoided at all possibilities. One of the discussions with Chris, he mentioned one more interesting thing, and which is very right and worth mentioning, that tibial cut should never be revised. So once you make a tibial cut, probably the revision of the you find it that
one femur,
yeah. The tibial revision should be avoided on the table.
Rajiv, sometimes you have to revise tibia, but it's not the depth; it's the coming more actually laterally. Sometimes we have not taken away enough tibia, and sometimes you find that the base plate probably needs to move a bit more laterally. There is no harm. He even takes away a few fibers of ACL. He doesn't mind that.
Very right. Yes.
So you got to be right in the center, where your vertical cut of the saw should be touching ACL actually.
Yes.
It should be touching ACL in the notch, and then only your cut probably is perfect. Now, Rakesh, how much do you remove? It's about 3 millimeters, 4 millimeters?
Yeah, 3 is what we aim for the G clamp. It comes with 3. But if you are a very big person, then I go for 4. But anything smaller, when you're very going to be size B or less, it will be size 3.
And second important thing here is in tibial fractures, intra-op fractures, I was going through all this, is the insertion of these pinholes. If you have to be very, very sure that you can just put 1 or 2 pinholes. If you put more than that and you take the vertical cut, sometimes that vertical cut can go down all the way up to the pinhole, and it can jeopardize the strength of the cancellous bone there. And then gradually over a period of time, the tibial tray will sink and you can have a fracture over maybe after 3-4 weeks, 6 weeks. So pinhole has to be 1 or 2 as necessary. I don't know. What do you say about that, Rajiv and Rakesh?
Yeah, I think that's why I think robotic is coming in a big way in this. Then there are no pinholes anymore in this.
Okay.
And also, I think you don't have any more smooth cuts. You have rough cut, so you don't need to make those extra peg holes also because the top layer is rough anyway.
Right. Ashit, one more thing very interesting to note here and to be discussed, that at what stage, if you have a peroperative fracture, you should convert it to the total knee. I think that in this situation, because I considered on the table that what is to be done, and what we decided is because the medial part was not collapsed. There was no total collapse of the tibial tray. It was just the compression at this point. And the stability of the joint, what Monty had rightly asked, was there. There was no instability. So that's why we maintained this case and took this step of fixing it up.
Sure.
But probably it is worth asking Professor Greichen if he's there, that at what stage operatively has he ever changed plan to total knee or any other faculty?
Yeah, Rajiv, I think if you are going to revise it on the table, then one problem you're going to face that you've gone down on the medial tibia a lot already.
Yeah.
And now if you have a fracture, you're looking at stem as your minimum salvage, or even some sort of augment on the medial side, which you may not be ready actually, at least the augment, you may not be ready at that time.
Right.
So going for a straightforward conversion may not be feasible, but that is why I'm saying it's another advantage of only cutting very minimal amount of tibia, that in case you have to go down, you can probably get away with a 12 poly or something. Otherwise you are doomed.
Right. And it is the most unfortunate complication because this goes only on the surgeon and the surgical team.
Right. Okay. Right. Rajiv, excellent case. Can you just stop sharing your screen?
Thank you so much.
I can got, yes, lovely. Okay. I'll share my screen. I have this.
Ashit, I want to ask one question at the end, and
Sure.
before we close, huh?
Yeah, no problem. That is fine.
And
No
I want
problem.
Krishna to actually answer that.
You want Krishna to answer that? Okay.
Yeah.
Right. Okay. So fine. I'll start with my visible and audible, right? So I'll start my case. Okay.
Yeah.
Right. We have this 64-year-old male who is a shopkeeper. He had pain in the left knee and difficulty in walking and standing. Conservative treatment was tried for 1 year and it failed. So on examination showed isolated middle compartment osteoarthritis of the left knee, range of movement excellent, 125-degree flexion, correctable deformity, lateral and patellofemoral compartment okay on the X-rays. So we offered him a medial unicompartment knee replacement surgery, which was done in January 2020. These are immediate post-op X-rays, and patient was doing well. Okay, now 2 months down the line, he slipped on a wet floor while coming out of his shop, and these are his X-rays. He met with this fracture, no distal neurovascular deficit, and this is what it is. So comments now, please. Rakesh?
Yeah, Ashit, nice one to start with. I think at this stage, probably I would do ORIF for this patient.
Okay. All right. Okay, fine. Any different view from any of the faculty?
Is there medial lateral instability? I think there is some instability, correct?
I should want to see about the ACL attachment, the tibial epicondyle.
The tibial spine, you mean? So there is that fracture going through that. So obviously we did a CT scan, which did not help us much. And then obviously there are the 3D CT images.
Yeah,
so,
right.
Yeah. So there is basically a fracture through the tibial spine. There is a fracture of the medial tibia, as you can see in this particular. This is the posterior view. So this is the fracture. This is the tibial spine fracture, and this is what it is.
So if you fix it, probably you will have to think about how to deal with the tibial spine.
Okay, right.
Also, the posterolateral corner is gone through the fibular head, so it's a ACL with a PLC type injuries. Like if you have a medial condyle fracture like this, in 40% of the cases, the posterolateral corner is injured. So you can see the lateral side is opening up.
Yes,
so
more.
This is much more complex than it is apparent on the X-ray.
X-ray, right. So what would you do, Kiran, at this stage? What is the plan now? What do we do?
How old is the patient? 64?
The patient is 64. 2 months after the primary medial UKR, which was doing well, he slipped on a wet floor.
I would go the ORIF way. So I would fix the posteromedial condyle posterior approach and then fix the fibular head as well, because the PLC, then I would assess probably the PLC if required. I would fix it because it looks unstable on you. Fix the medial condyle first and see if it is looking reasonably okay. It's not opening on the lateral side, then probably immobilize it in a brace for a few weeks and see. But if it is unstable on the lateral side, then it would need addressing as well.
And how would you fix that fibular head? You said, how would you go about the fixation on the lateral side?
You can put a few screws through the top of the fibular head into the shaft. Yeah.
Okay.
A couple of screws.
Kiran, the fracture fibula is not displaced; it is just in position.
Yeah, absolutely. So I would assess it. I would. That is something which would worry me, because if it's an ACL posteromedial condyle with a PLC, it's likely to be unstable later on. So if we make a decision to fix it, we must be sure that PLC lesion will heal. And sometimes the PLC don't do that well. So if you just leave a medial uni and fix it, and then it becomes unstable, and then you have to do a TKR at a later date, that becomes a challenge.
Sure.
So might as well commit on a TKR now, because then you can address everything in one go. So that's tempting actually to put a stem extension and then do it. But if you're trying to
primary TKR at this stage, right?
Yeah, that's an easier option out, right? It's like it will address everything. So you can look at the intra-op instability issues, stuff, everything. Choose your constraint, put a stem extension, do everything in one go, and the patient will not require a second surgery. But if you choose now to fix it, we have so many issues now. The tibial condyle, whether it will heal without collapse. What about the ACL avulsion, and what about the residual posterolateral corner instability? So 3 things which we need to consider.
Sure.
So if it's not a simple decision,
if you were to do a TKR, would you have to use probably sleeve, because there is complete this fracture of the medial tibial condyle. So moment you start doing a tibial cut or start reaming, the whole thing probably can open up, because there will be multiple small little fracture lines which we can't see here. So would you consider what implant? Stem and everything understood, but would you keep sleeve also as your in your
absolutely repertoire? Nowadays metaphyseal, so I wouldn't attempt any revision without a metaphyseal sleeve as a backup. So if it is required, I will use a metaphyseal sleeve. So I have no problem with that.
Sure.
Okay, so you would, I won't.
So you would do that primarily as if you are planning the TKR right now at this stage.
No, the first plan is to fix it. The first plan is to fix it, but I would keep everything on standby. Like, it's not something which I would just attempt lightly, just fixation of the medial condyle and leave it like that, because a lot of issues to be addressed here.
Because if you're trying fixation, you are doing it through a prone approach, prone position and posterior approach. And if you are trying to do a constrained TKR, it is straightforward supine position and with the knee bent at 90 degrees. So everything will probably intra-op. You will not be able to change your decision very easily. So I think so. It has to be one decision: whether you fix it, put the patient prone and fix it, or you make him supine and do a constrained total knee with sleeve and stem, whatever is needed for the bone reconstruct. That's what I think.
That's a good question. So I would have a chat with the patient, tell them about the issues related to the thing, and I would not try. I would not be afraid to flip the patient back from prone. So I would first try and fix this thing up, reassess everything, and try and fix it wherever possible. But if I'm not happy with the fixation, I'll flip the patient and then do a TKR in that stage. I will not wait for a failure at a later date.
Lovely. Okay. So we took him to the theater. I took help of one of my colleagues who is a trauma specialist, Dr. Gawale, and we did the fixation. We put the patient in prone position, and that's the reduction and that buttress plate from the posterior medial approach. And if you see, this is the immediate post-operative X-ray. Patient was kept non-weight bearing on walker for 6 weeks, and next 6 weeks from non-weight bearing to full weight bearing. Hinged knee brace to support during flexion from 4 to 12 weeks. And at 12 weeks, full weight bearing, no walking aid, no brace. So this is the picture immediate post-op after fixation. Any comments?
Yeah, Ashit, I think there was a lateral side injury also. I think the CT scans were not adequate, but in post-op you can make out that there was injury to the lateral condyle also.
Lateral condyle of the tibia.
Yeah.
Okay.
So which I think we have not fixed. So it has collapsed a bit.
And even the tibia is sloping. That is also not very good position.
Right. Okay. Okay. So I would, fine, take the point, but I would rather be more worried about the slight valgus that you can see, whether this patient has an MCL, which is not, in the appropriate tension. So anyway.
The reason for this valgus could be that lateral tibial condyle is a little bit of collapse at the lateral tibial condyle.
Yes.
That could be the reason of why the patient is having valgus.
You mean here, somewhere here?
Yes.
There.
There's a collapse.
Collapse there, right. Okay. Anyway, so this is what it is. Okay. 3 months down the line. Okay. Fracture seems to be healing.
Right.
He is delighted. This is the UKR incision. This is the plate incision. We can certainly see that valgus, very obvious from behind, but he has full functional recovery. He is very happy. I am not happy when he comes into my OPD, but he is very happy. He said, fine, thank you very much, doctor. So I said, fine, no problem. So No. So now I said, no, you keep coming every month to me because I want to see. So this was 3 months post-op X-ray and his recovery. Now this is 6 months. He is now going into valgus. Clear cut, he is into valgus. The tibiofemoral angulation is more than about 12 degrees in valgus. Now, as far as both the operations are concerned, he is happy. He has no arthritis pain on the medial side. His fracture is healed. So he is happy. But I am not happy because now it is 9 months and this is what is the situation. I have kept him in a brace. Now, I have not operated him as yet. This is the recent X-ray. And this is what I want the suggestion from the entire panel. What do we do now? He is in valgus.
As long as the patient is happy, why you want to touch?
No, because see, he has Shubhranshu, he has got valgus stress. It opens up medially. He has got anterior posterior laxity also. So anterior draws is also positive. So it is just a question of time that things are going to fall apart.
So is there MCL laxity now?
Yeah. MCL is lax. ACL is lax, though that tibial conduct, the tibial eminence fracture is healed, but the ACL is lax. MCL is lax. And
so the only option is TKR, and you should continue as long as he manages. And the only answer is TKR.
This is what I was actually bringing this out when I was saying that
exactly
it's not a simple decision, because
it's true.
It's a multi-ligament injury now with a uni.
Yes.
So he would have probably, in hindsight, be better off with a knee replacement at that point in time. Although it was too much of an operation.
Yes.
Probably better off because now he's been operated twice already.
Yes.
And now you will still have to put him prone and then flip him back because you need to remove the plate.
Yeah, that's a real problem, removing the plate.
But you see, Akshay, there is one question which is a major issue. When you have a fracture as a fresh fracture, you do a total knee replacement. You want to put even if you want to put a metaphyseal sleeve, the whole proximal tibia will just open up.
Yes.
The only fixation that will happen will be mainly with the stem. And will it be a good idea, or it is a good idea to operate the total knee replacement at this stage when the fracture is united? Kiran, what do you say? Ashit.
The biggest problem is removing the plate now. It's more
proximal screws. That's all.
Dr. Ashit, what can we say? What's the reason for this? In hindsight, what we would have done better during fixation stage to avoid this? You were planning, everything went off okay.
Yes.
So in hindsight, what you would like to improve upon in fixation part?
I think so. The fixation part, the metal work and everything is okay. What probably we missed out was the soft tissue injury, the medial collateral at that time. And as Kiran was mentioning about the lateral opening of the knee, because see, right now, both the operations have done well. Patient has no medial knee joint pain for which he came to me, and the fracture that happened is healed. Now the problem is the instability. So instability is something that we did not address at the time of fracture surgery. And that is what we should have done something about it. And if I feel as an arthroplasty surgeon, if I'm not very good at doing reconstructions and all soft tissue reconstruction, we could have gone similarly in the lines Kiran was talking about, putting a constrained knee with a metaphyseal sleeve. In hindsight, I feel that would have been the right choice. One operation for a 64-year-old gentleman, and everything, all these problems would have got solved.
But he must not have had the MCL injury as a primary this thing. It's very rare to get a fracture of the medial condyle, MCL injury along with the...
No, but we deal with a lot of multi-ligament injuries. It's not uncommon to have MCL as well as PLC injury. So even
that is okay, but not with the fracture, this thing of the medial side.
No, that's what I'm saying. Even with the fracture, it is not unlikely to have a stretch of the MCL in these injuries.
See, now with all that you have seen what has happened, now would you comment on this immediate post-op X-ray? Understand, fracture is reduced nicely. Whether have we missed out on the medial collateral ligament injury, or something would have been done better at that stage in terms of soft tissue reconstruction, and we should have got the limb aligned properly, we could have avoided this complication now. Anyone on this?
No, I
think we have gone for MRI at the initial stage also, because the implant is compatible with the MRI to give us
artifacts will come.
A lot of artifacts will come because of the uni. See, MRI at this stage, the plate is okay, but the uni will throw a lot of artifacts.
So the key here would have been a clinical examination once you finish your fixation. That's what I was alluding to. You finish the fixation, you do the pivot shift, you do the dial test and look for the PLC injuries. If there is a significant injury, at that point in time, you must convert it into a TKR, because I don't think these injuries, multi-ligament injuries with a uni is a great option, so you would not leave the uni in. So you would clinically evaluate. That's what I was meaning when I said if I do the fixation, I would reassess the patient after fixation for ACL competence. I would look at the PLC situation, even if it is undisplaced. If it is a clinically unstable situation, I would not be comfortable leaving a uni inside.
Yeah, but everything you would do at the same stage. Once you've beautifully fixed like this.
Problem. Anyhow, as Dr. Rajiv pointed out, you need to fix that fracture, right? So what better than to fix it from the back? So you just put a buttress plate and then put a TKR implant. Not a big deal. So you can put a unicortical plate rather than a bicortical, because everything is open at that stage. You would assess it, open the wound up, convert it into unicortical plate, put a sleeve with a stem extension. It's a more extensive procedure, but a one-stop solution for the patient.
So you suggest that you put a sleeve, stem, TKR, and a posterior buttress.
If you actually,
it would have been really extensive surgery.
No need for a sleeve. There is no need for a sleeve. You can keep the sleeve as a standby. I was just keep it as a standby. You could just stem it. You could stem it and use a unicortical plate to stabilize that posterior medial cortex.
Sure.
You can stem it. That's it.
Okay. All right. So this is where we stand. And now, so we'll have to.
Let's move ahead. It's really lagging time.
Okay. So thank you very much for that case. I'll stop sharing my screen. And can I invite Dr. Bhosle, please, for his case?
Yeah. By the time Dr. Bhosle is sharing his screen, any literature you have on this?
Okay. So that was very, very interesting. There is no literature on periprosthetic fracture. One particular book there was a chapter in that particular book that I mentioned. And there also periprosthetic, they mention exactly the management is same as we do it for UKR, that you have to check for the stability of the implant. But no one talks about the stability due to ligamentous injury in a periprosthetic setting. So there's only one particular literature that I saw, which says that if the implant is stable, fix it. If implant is loose, make a do a constrained arthroplasty. But here our problem is different. Our problem is not the loosening or anything. Our problem is ligamentous instability.
Okay.
Anyway, Dr. Bhosle, please.
Yeah. So as a lot of discussion has occurred on mobile, so I'll present a case of mobile poly dislocation. So this is 51-year-old patient, BMI 28, UKR 1 year done by us. Patient had near normal activities, sitting cross-legged. She was praying every day, and 10 months everything was perfect. Since last 2 months, she was getting posterior medial pain, occasional clicking and locking, which was resolving on range of movement. And she presented with this picture. You can see there's a clear-cut anterior dislocation of the mobile Oxford poly. So this was a pre-op picture before we operated, 50-year-old female, and everything was as per the requirement, anterior medial OA. And this is a day 1 picture. So any comments on this? We use 4 mm poly and Oxford mobile bearing. This is a day 1 picture. This is 8 months. Any comments? 8 months post-op. Yes. So everything was fine. And this is 1 year when she came to us with this picture. You can see both those views. So 51-year-old, no signs of infection, no obvious loosening, implant position okay, mobile bearing. Shall I go ahead?
Can you just show us the X-ray, please? The dislocated poly, the AP X-ray, please. Yeah, okay.
What was the stability on the table?
It was
post-operative, yeah.
Yeah, patient was enjoying movement.
No, I mean on examination.
Everything was fine for 10 months.
Okay.
She was every day praying, sitting on the floor and doing regular every day, and stable for 10 months. Maybe she was overdoing it. And last 2 months, there was a problem, it was pain, there was a clicking. She did not present it to us, but when she presented, it was completely dislocated.
I mean, obviously, this X-ray shows there is loosening of the tibial component, because you can see that halo around the tibial plate,
Yes,
especially
yes.
the tibial.
So,
and
it was definitely there's osteolysis here,
right,
and
bearing that has come out.
Okay,
but,
so one
but a
option.
millimeter or two of non-progressive radiolucency around the Oxford is a normal phenomenon.
Yes, that's true. That's also
it is not suggestive of loosening. You should
But-
just follow that patient up.
But as early as 1 year, this is only 1 year since the surgery.
Yeah, it can happen anytime after 10 months to a year, and it persists for a long period of time. As long as it is non-progressive, uniform, less than 2 millimeters, you should not be worried with an Oxford. So the loosening is an overdiagnosis. I don't think it's loosening.
It's not a loosening, but it will be debonding, you can tell.
Debonding of this. Because there is hardly any
remodeling
cement
around the Oxford sometimes.
Yeah, okay.
The tibial bone remodels. So that has been clearly shown by the Oxford group. It's not a danger sign. If the component is well fixed intraoperative, poly exchange will be the way to go for a well functioning unicompartmental with a bearing spin out for the first time.
So exactly, intraoperatively you can decide whether it was loose, and both the components were firmly fixed, confirmed intraoperatively, and we have to change 4 to 7 poly, and it was stable with that. This was the only poly, 7 poly, which was quite stable, and we had to put that. I know thicker poly is a bad option, but we had not cut too much of bone also, but this was a stable poly, most stable poly. So lateral X-ray. This is 1 year post-op, 7 mm poly. Everything was fine. This loosening line is seen, but it was quite stable both on AP and lateral. And this is 4 years. Osteolysis is here, but tibia was looking okay on the X-ray. This is a lateral X-ray. And
the tibial spine thing is normal because you don't cement it. Then there is no loading there. It should not be a problem.
Yeah. So this is a complete X-ray 4 year, and she is the patient. We just called her specially for this meeting, and she is enjoying her moment. No pain, and only thing is we restricted her to sit on the floor and prayers.
Okay.
So Pradeep, 2 observations. One, you did not have a very acute injury in this one. It was a progression probably over a 2 months.
That's
so,
right.
We believe that the dislocation might have happened 2 months ago. Now she's been walking actually on the metallic components articulating with each other.
Right.
So that would have roughened your femoral condyle a lot. Now that articulating with a smooth poly.
It was a mobile poly. So there was I checked that your point is very correct, but it was good. There was no damage or scratches on the femur.
Okay, so that's
because
one point.
She was not walking.
It might be microscopic, which is not
her
visible.
activity was very low. She was suffering with pain. So the causes of mobile polydislocation so there are 4 prominent causes as it was well described by you. So unbalance, flexion extension gap, impingement, instability because of the MCL injury, or component loosening. And as everybody knows, UK complications are definitely more than TKA by most of the authors. And this is one of the largest study, and mobile bearing dislocation is one of the very large component of complication.
Right. All right.
And mobile bearing, the problem is with the dislocation, and fixed bearing is a aseptic component loosening.
Right.
Fine,
okay. Thank you very much, Dr. Bhosle.
Dr. Bhosle, one more point. You went from poly 4 to poly 7.
Yes.
Anything to make you worried? Why was there such a gap which has opened up so much?
Because probably I think 2 months she was just maybe that's a reason. It was not acute. So probably she was roaming around with that unstable poly. But I was very surprised.
Do you think the deep MCL was still intact?
Intact. It was intact. So 7 poly was the only poly which was perfect.
Actually, I would like to add one point here. As she was enjoying all the movements, what we
8
usually,
months, 10 months before.
yes, if we see the X-ray carefully,
Yeah.
and this is recently been noticed that if your femoral component is bit medialized, you will have lot of space between your vertical tibial plate and the poly. And if this lady doing everything, sitting on floor and squatting and doing everything, the anteromedial, in extension, the poly comes anteromedially and then it drives back posterolaterally. And then there is a lot of room for the poly. So there is mild subluxations over a period of time, and that would have stretched your MCL. So it is not a damaged MCL because there is a lot of space. The poly is too free. If it is too tight, it is too impinged. That is also a bad thing. But this is a too much space for the poly to move from anteromedial to posterolateral, and then it rotates sometimes, leaving less congruent area, and then chronically it would have stretched the MCL, and that's why one fine day it has dislocated, and that's why you ended up in a 7. You have to put 7.
Karthik, not just chronic, but I have felt that on the table also, Pradeep, that while sort of, sometimes you feel you want to cut a bit more osteophyte, you go behind and suddenly the deep MCL is in your hand. So the poly, which was now being sized at 3, suddenly opens up to 6. It's happened to me on the table.
Rakesh, when we used to do the LCS knee and a few cases which had a poly spin out, we realized that those patients who were walking on the poly and after they spin out, they had the stretched MCL. What Karthik is rightly saying that it could be a chronic stretching of the MCL.
His case is chronic, definitely.
Yeah.
And so that is my question to all the faculties. So in hanging leg in 90 degree or 110 degree flexion, with a trial reduction, what is the distance you accept between your vertical tibial plate and your trial poly or the original poly?
It should be perpendicular, femur and that, yeah.
Between the tibial vertical base plate or metal part and the polyethylene, what could be the distance? If it is too tight, if it is touching, we know this is a small tibia and it is impinging. That is not acceptable. But if your femur is in the two medial side, so as the recent recommendation is to on the lateral half of a middle third. So that is ideal. So it should be not too much space. If you are able to put your cautery and just toggle, and it gives you a 4 millimeter space between a vertical cut and polyethylene, especially in male patient like D tibia, medium femur, and there's a lot of space in between, and you have medialized your femur. This is going to give this kind of 1 year, 2 year, 3 years, slow, gradual, chronically injured MCL and dislocation.
Sure. Shall we move on, please? Yeah. Shall we move on, please?
Yeah, the last case, which is a millimeter or 2, and see that it is not touching. And millimeter or 2 is what I would accept.
But Karthik, with Oxford, you're going to get not only forward and backward, you're also going to get rotational things. So at some stage, it's going to hit it. There's just too much of movement in Oxford.
Yes, agree.
Shall we move on, please, boys?
Yeah.
We can have the discussion later on. So last case we have is from Krishna Kiran. Krishna is presenting his case. Krishna, go ahead.
So this is an unusual case of early femoral component loosening, which was the first of the 2 cases which I saw in my series. So I was doing Oxford knee for a long period of time, and also computer navigated assisted Univation XM, which is an Oxford copy, but as we found out later on, it was not as good as the Oxford. Like Dr. Rakesh mentioned, not all mobile bearings are the same. And we had a couple of early femoral component loosenings with navigation. So this was a 58-year-old man with bone-on-bone anteromedial arthritis. ACL was intact. And he had a very spontaneous osteonecrosis of the knee on MRI, and he was symptomatic to warrant intervention. So we went ahead and did a standard computer-assisted uni. And one of the reasons why I would do CAS uni is that it will give us the correctability of the deformity, not only in the coronal plane, but also the presence or absence of hyperextension deformity intraoperatively. So some of the times uni fails because there is hyperextension, and you cannot correct 5 or 7 degrees of hyperextension on table because you don't recognize it in manual knee replacement. So one of the concerns with Oxford knee I had was I was unable to recognize the hyperextension. And I had at least 10 or 11 cases where I did not proceed with the uni because the navigation showed that it was 10 degree of hyperextension. So this is one thing which is not talked about. And I spoke to Hemant Pandit also. He says there's no evidence on hyperextension. So that's what it is. So in this, so you can plan your tibial cut. You can see the deformity. You can see it's around 4 degrees. And you can see the tibial cut, which is planned at less than 7 degrees of slope, because we know that more than 7 degrees will cause premature problems with the mobile bearing uni. So 7 is probably what we would accept, a 4 millimeter cut. And you verify the femoral cut, you know the size of the polyethylene 00. 7 is the minimum thickness in univation. And that's what we got, 7 millimeter. We balanced the gaps. And this was the final picture, 1 degree of varus. And throughout the range of motion, it was 1 degree of varus. So we don't aim for overcorrection. But some patients we found with navigation that they would go into 3 or 4 degrees of valgus also, which we will not be able to know with manual surgery, whether there is overcorrection into valgus. So that's why we chose to use technology. And this is the immediate post-operative X-ray, which was absolutely fine. There was no problem with the thing. Femur was cemented. There was cement distal to the femoral pegs. The tibial slope was good. And the femoral tibial divergence angle was acceptable. And the overall alignment was fine in this particular patient. So he did extremely well for 18 months. So he was doing everything, sitting on the floor, squatting, very, very happy, and started complaining of pain for 2 to 4 months before he presented to us on the medial aspect of the distal femur. And these were his x-rays. So not very this thing, but as Karthik pointed out, the only flaw with this was a too much of space between the lateral cut of the tibia and the femoral component, which was probably more medialized, and it was not that clear, but it's definitely clear even in the immediate post-operative X-ray. The gap would be more than what I would normally accept. It's more than 4 or 5 millimeter. Apart from that, there is no other issue with the thing. So he presented 2 years post-surgery. These are the X-rays. ESR and CRP were normal. And he was having problem with weight bearing. The range of motion, everything was fine. But every time he would put weight on the leg, it would be painful on the distal medial aspect of the thigh. So any comments here? Anything which...
Yeah, Krishna, I think, I don't think you need to be too harsh on yourself that the gap was a bit wide. And because, this original diagnosis was SONC. And I think you had further collapse because of the osteonecrosis rather than actually something else happening. Yeah,
absolutely. So that's a very, very valid point you bring out. So I looked at the literature and they say that if you have a large SONC lesion around 4 or more centimeters in size, there is a potential for progressive collapse and increasing involvement of the metaphysis of the femur, and it can contribute to premature loosening of the femoral component, which probably what happened in this particular case. And this is the way to identify femoral loosening, which is otherwise, difficult to identify. So you must get an X-ray in 20 degrees of flexion and 90 degrees of flexion. And on 90 degrees of flexion, you can see the crescent sign between the anterior part of the femoral component and the bone. And on the extension X-ray, you will see the wedge sign between the posterior part of the cut femoral surface and the posterior part of the femoral component. So we did the X-ray in extension and flexion, and we could figure out that there was something wrong with the femoral component. So this was a case of early femoral component loosening. And as Dr. Rakesh rightly pointed out, was because of progression of the SONC lesion. The femoral component loosening is an uncommon complication following uni, and the incidence ranges from 0 to 2.1%. So in my series of around 150 cases, I have seen 3 cases of early femoral component loosening. All 3 were in men who were very active, and all 3 had spontaneous osteonecrosis of the knee. So now I do not do unicompartmental knee replacement when I identify a large SONC. If it's a large SONC, then I would not do, because it's 3 cases in 150. I haven't had failures for other indications using a unicompartmental knee replacement. So some of the technical problems are if you have excessive anterior sloping of the posterior socket, if you don't pressurize the pegs adequately, you don't make adequate drill holes and make good pressurization of the cement, it can fail because of the sclerotic distal femur. So these are all the causes of early femoral failure. So obviously this required revision. So this is the picture at revision. You can see that the Sonk lesion had progressed indeed, and it involved more part of the metaphysis there, and that was after the total knee replacement. We were able to use navigation, as you can see the pins, to navigate our distal femoral cut and the proximal tibial cut, and we used the lateral cut as a graft and then use the stem extension. The patient is doing well. Point specific to this patient, young active male patient with a Sonk lesion of the femur, which is of grade 3 or a severe grade, should be a relative contraindication for a uni, in my book at least. And the Univation XM has got a more constrained poly than Oxford. So this is probably one of the reasons, because I was speaking to Dr. Rajesh Malhotra, who has done several of these navigated unis as well. And he also found that some of the patients did have a higher incidence of femoral component loosening. So whether there was a design issue with Univation XM, so we've written to them. So they're looking into this matter, whether there is any actual design issue with the highly congruous bearing, which is more congruous than the Oxford and cannot be inserted from the front. You have to insert it from the side. So that was another point which we thought may be a reason. And the Asculab guys are investigating this particular at this point. Thank you.
Thank you.
How many months post-op?
2 years.
2 years.
This was 2 years, sir.
Okay, 2 years. Okay.
Right. Thank you very much, guys. Do we have any questions from delegates who are watching? Doctor?
Not many. No.
Not many?
Yeah.
All right. Fine.
Yeah,
So,
Rakesh wanted to ask a question.
last question he wanted to ask. Yes. Rakesh, are you around?
You have to unmute yourself, Rakesh.
Sorry. There was another land phone ringing. I had muted myself. I just want to ask everybody here that we've been quite used to Oxford, and Oxford themselves realized that since they moved into minimal access surgery compared to the usual big ones, their success rates actually improved in many accounts, regarding DVTs, regarding infection, regarding patient satisfaction. Now, when you are moving into robotics, again, the incision is getting actually bigger. You need to see much more, and also you need to probably subluxate the patella to some extent. Are we again losing out something in trying to gain something? I mean, I'm actually confused at this moment. So anybody who's doing robotic and both maybe can clarify this point.
Yeah, so I've got some experience with robotic as well as minimal invasive. In fact, we looked at CAS, because even CAS involves putting in pins, and although the incision is similar to that of an Oxford, it is definitely more invasive than an Oxford microplasty. We looked at 60 consecutive patients with Oxford versus 60 with CAS, and actually there was no difference using the Oxford criteria with respect to the radiological outcome. Clinical outcome was superior in the Oxford group as compared to the computer navigation assisted. The role of robotics comes when we are using a fixed bearing uni. It will not come in a mobile bearing. So if you're using Oxford, I think you should stick to Oxford. You should not change to anything else. But if somebody wants to do a fixed bearing uni, that's where technology comes in, because you can actually look at the loads, load lines, look at the edge loading, look at where your component positioning is there. So somebody who's doing Oxford, I think you should not change. You just stick to Oxford, do the microplasty. It's as good as anything else if it's good in your hands. But if somebody is doing a fixed bearing, definitely they must use technology, because there's no way of putting a fixed bearing uni right without the CAS or the robotic in each and every case.
Perfect.
Lovely. Right. So if there are no more questions, thank you very much, everyone, all the faculty and all the delegates, and thank you to two guest speakers. I hand it over back to Mohanty, because we probably have overrun with the time, but overall it was a good exposure to different kinds of unicompartment knee replacement, the guest speakers, the body of the webinar, and to end with the case discussions. So over to you, Dr. Mohanty. Thank you very much for all the help, and thank you very much, Kiran, for helping me out with the making of the brochures and the end moment changes.
Thank you. Thank you, Asit, for convening this webinar number 11. And on behalf of Indian Arthroplasty Association, I extend my heartfelt thanks to all the faculty, or both guest faculties as well as all the Indian faculties. Our next webinar will be IAA 362 webinar series number 12 on managing femoral bone loss in total hip arthroplasty. And it is scheduled for the third Tuesday of January, that is 19th January 2021. And Dr. Rakesh Rajput and Dr. Devabrat Padi, they have kindly consented to become the conveners for this symposia, and it will be very interesting to watch this webinar. So I request all of you to join this webinar on 19th January evening. And have a nice, good evening, and wish you all the best and best of health. Thank you very much.
Thank you. Thank you, everyone.
Thank you.
Thank you.
Can you stop live streaming, Swapnil?
Sir, actually my internet gave way. I think you are the host now, so you will have to stop it.